Hello everyone, good evening. Can you all hear me? Yes. Guys, everything is fine, audio and video. Shall we start the class? Okay, hope everything is fine from my side.
Yes, ma'am, you're audible. We can start.
Yes, okay. So guys, today we are going to understand few of the important image-based questions which are very frequently repeated in the FMG exam. So our main focus is on FMG today. So in that also we are going to understand the most important image-based questions, right? These are usually ortho. Usually at least 2-3 questions will be image-based questions. So that is why I have taken this topic and extensively I have covered all the important images which can appear in your coming exam, right? So always remember that one of the most important thing you have to study is regarding the orthopedic oncology, right? So this is one of the most integrated radiology plus ortho. So it will be easy for the examiner to ask the integrated questions which combines both radiology and ortho, and that important chapter would be your orthopedic oncology, right? And one more important topic is pediatric orthopedics. So in case of pediatric orthopedics also, usually what they do is they put the x-rays mainly related to rickets, right? So this is pediatric plus ortho integration which can usually occur, right, in the exam. Okay. And then one more thing very important is the metabolic disorders. So whenever they want to ask something about the metabolic disorders also, they usually give this IBQ, that is image based questions, right? And finally trauma. So in trauma, what is the most important thing you have to read? The fractures, right? And then the splints, right? Recently in Jan you have seen there has been asking about the BB splint, right? Bowler-Brown splint has been asked recently in the exam. So when it comes to trauma, they usually ask about the fractures. They put up the x-ray of the fractures and then they put up the x-rays of the splints, which are mainly used in case of your nerve injuries, right? So these are the one sector of preparation for ortho, especially regarding your IBQ, right? So now I have been starting the class with the image based questions mainly from the orthopedic oncology as I've told, right? So now keep answering the questions because this is like a revision for you, and you have to identify maximum of the images so that it will be easy for you. Even though you go wrong, keep identifying the images. Okay, the first one, the most important one, most easiest one. Yes, what is the answer for the first one?
Osteochondral.
Yes, very good, Rishabh. The answer is absolutely right. This is called the osteochondroma. So 2 or 3 points we will learn in each image so that it will be like a revision for us. So osteochondroma is also called as exostosis, right? So this is also called as exostosis. This is nothing but, this is not an original tumor. This is nothing but, we say this as an aberrant of the growth plate. So what does that mean, aberrant of the growth plate? That means there is some disturbance in the growth plate. So this is the growth plate, right? So epiphysis, you have the growth plate, and this growth plate, there will be some disturbance in the growth plate. Hence, there will be an extra growth which is away from the joint, right? And as soon as the person completes the age growth phase, usually it ceases, right? Usually it ceases and does not require a surgery. It is not a true tumor. This you have to remember. So they can ask you as which of the following statement is incorrect or correct. What you have to remember regarding exostosis is, first, it is a abnormal growth. Why there is an abnormal growth which is happening? Because there is some disturbance in the growth plate which is occurring. So there is an abnormal growth. And what is the one important feature which you have to remember for exostosis? You see there is a continuation of the marrow. Right? So you see there is three important features you have to identify here. So this is the cartilage cap which is present over the bone, which is usually not seen on the X-ray, right? So you will see there is a bone, cortex, right? And plus the marrow, what I have told you, and then it is covered by a cartilaginous cap. Right, so this is the very, very important feature which you have to look on the CT or MRI. So the entire growth is like a bone itself. So it will have cortex on either side. In between there is a marrow and it is covered by the cartilaginous cap, and this cap is usually not seen on the X-ray. So whatever the image you see on the X-ray, it is comparatively smaller clinic. Right? So that is what you have to remember. And as I've told you, this is not a true tumor. Then why you want to remove it and why are you worried about it? What happens is there is a chance of this tumor creating bursitis, or it causes compression over the adjacent vessel or the nerve, right? Sometimes for the cosmetic regions, and sometimes it can turn into a malignancy, right? So these are the few important things which you have to keep in your mind, so that why people usually go for surgery in case of your exostosis, right? So usually the answer would be, it could be because of the bursitis or compression of the adjacent vessel or the nerve. Cosmetic purpose, because there is a swelling, usually they feel that, you know, it is abnormal for them, not normal. And then there is a high chance of this converting into malignancy. Especially what converts into malignancy? What is the risk factor here for the malignancy? The cartilaginous cap, right? There is a high chance of this cartilaginous cap converting into a malignancy, right? So that those are some of the important points which you have to remember about the exostosis. Is that fine? Any doubt? Yes, guys, anything you want me to repeat, or is it fine? Okay, let's move on to the next one. So what is the next one? What is this? So we are done with the exostosis. What is the second one? What are you seeing on the screen? Yes. So there is usually, whenever you see this particular X-ray, you see nothing here, right? Nothing specific here. As what you actually see is some sclerosis over that. But what is important here? What is this investigation which I'm showing it on the other side? This is a CT scan, right? So this is a CT scan. And what are you seeing on the CT scan? There is a nidus, if you can observe, there is a nidus. So this is the nidus, what I'm seeing on the CT scan, right? So this nidus is what? What is this nidus? And where exactly I'm seeing? I'm seeing in the diaphysis region, if you remember. And where did I see this exostosis? In the metaphysis, right? Exostosis I have seen in the metaphyseal region, right? Metaphyseal region. And this I'm seeing in the diaphysis. And what I am seeing? A nidus which is less than 2 centimeters, right? A nidus which is less than 2 centimeters. And what is the very peculiar thing about this? So what is actually this? Have you identified? This is your osteoid. Very good. It is osteoid osteoma. So what is osteoid osteoma? It is a nidus which is usually seen in the diaphysis, where the size of the nidus is less than 2 centimeters. That is very, very important. And what is it? There is release of this prostaglandins, especially during the night time, right? This is a very peculiar feature, right? And it relieved by the pain. Whenever there is prostaglandins release, what do? They cause pain, right? So how is this pain relieved? It is relieved by taking your classical NSAIDs, and this is also considered as one of the tests for your osteoid osteoma. Okay, so usually they confuse you by putting up only this X-ray, right? So that is why you have to be very clear, read the history properly. In the history, they'll give you that the patient has complained about pain, and this pain is usually more worse at the night time, and it is usually relieved by NSAIDs, right? Then what do you think is the treatment would be for this? Radio frequency? No, radio frequency ablation. So the advancement is there is a radio frequency ablation which we can give because the nidus is very, very small. Okay, so you go for radio frequency ablation. So this has been asked in the exam as a match the following. Treatment for osteoid osteoma is RF ablation. Okay, and sometimes you can even go for excision also. But as the nidus is very, very small, we usually go for radio frequency ablation. Okay. Okay, good. And then what is this? The next one. Very important. Frequently, they keep asking you this one. You can see some deformity. Yes.
Fibrous dysplasia.
Yes, it is fibrous dysplasia.
Fibrous.
Yeah. What is the deformity? It is called the Shepherd-Crook deformity. It is the Shepherd-Crook deformity. So it is usually like this, Shepherd-Crook, right? So this is called the Shepherd-Crook deformity, fibrous dysplasia. What exactly happens in this? What happens is the bone is completely replaced by the fibrous tissue. It is replaced by the fibrous tissue, hence it appears as the ground glass appearance. So this is the name given to it is ground glass appearance, right? And one of the most important deformity which you have to remember is the Shepherd-Crook deformity. And what is the syndrome which is associated with this? Where it is seen as precocious puberty. Which Shepherd-Crook deformity? That is fibrous dysplasia. What is that important syndrome? It is yes, very good. The 𝐒𝐄𝐝 syndrome. It is the 𝐒𝐄𝐝 syndrome where you see multiple fibrous dysplasias, and then you see precocious puberty with this condition, right? This is called the 𝐒𝐄𝐝 syndrome. Again, this is also a MCQ, right? They put up this X-ray and they will ask you to identify what is the syndrome associated with it, and the answer would be 𝐒𝐄𝐝 syndrome. Is that fine? Okay, then the next one, it has been already mentioned here. So these are all the benign, right? These are all the benign tumors what we are discussing. So this is the unicameral bone cyst. Yeah. Unicameral bone cyst, or it is also called as the simple bone cyst, right? So what is a cyst? Cyst is nothing but something which is filled with the fluid, right? So cyst is nothing but something which is filled with the fluid, and whenever this appears in the bone, this is called as a simple bone cyst. But why are you worried about the simple bone cyst? Usually this might result in fractures, right? Because the bone is weakened there, they might result in fractures. And when you see there is a fracture fragment which is seen into the cyst, what is that called? What is the name given to it? Fallen leaf sign, right? This is called as the fallen leaf sign. So what happens in the fallen leaf sign? So whenever there is a fracture, you see there is a small fragment into the cyst cavity. So this is called a fallen leaf sign, right? Or a trap door sign. Fallen leaf sign or the trap door sign. That is, you have to remember about the. And what is this fracture called? Whenever there is a fracture which is seen in the cyst form, what is that fracture called? A specific name given to it. It is called the pathological fracture, right? It is the pathological fracture because the bone is already weakened there. Hence, this is called as the pathological fracture. You have to remember simple bone cyst usually appears in the metaphyseal region. Metaphyseal region, as you see, there is a cyst which is just a fluid-filled area. And whenever there is a fracture, this is called as the fallen leaf sign. Is that clear? What is the next one? Next one, what is this? As you can see, now you have to... What?
Giant cell tumor.
Yeah, this could be giant cell. So now you have to be very, very careful. How many of you are thinking that this is giant cell tumor? So if you think this is giant cell, then what is this? So how do you differentiate between that and this? So one of the most important thing what you have to remember is the location of the tumor. So if you see here, the tumor is in the metaphyseal region, right? And here if you see it is in the... Yes? In this image it is where is the... Huh? Very good, very good, very good. So it is in the epiphyseal region. So this is how you have to be very careful in the exam, right? So you have to properly evaluate, right? So if you see, this is the area, it is still free here. There is no tumor here. But epiphyseal, see, now you see the entire joint space. It is not entering the joint space, but it is from the starting of the bone, that is from the epiphysis, right? So whenever something is from the epiphysis, then only it is related to giant cell, that is GCT. And this is one of the most important, very, 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 very important tumor. You have to remember about everything about this. So what is this? This is epiphyseal tumor. It is called the giant cell tumor. What is the other name which is given to it? It is also called the... Very good. Osteoblastoma. What is the appearance? How it is appearing? So bubble appearance. And finally, what you have to remember, the treatment. So what is the treatment for this? So before telling the treatment, you have to remember one more thing. What is it? This tumor is supposed to be an aggressive tumor. This is called an aggressive tumor. Why it is called aggressive tumor? What is the main problem with the GCT? So there are chances of the recurrence, right? It is usually recurrent. So whenever something is recurrent, something is bothering us so much, it is said to be a benign tumor, but an aggressive tumor because of this ability to recur, right? So what do you do? Just curettage will be sufficient for this such aggressive tumor. What we are going to do? We are going to do
Extended curettage.
very good. The treatment is extended curettage. You have to remember this, extended curettage. So what do you mean by extended curettage? So here, this is ABC, right? Whatever we see in the metaphyseal region is aneurysmal bone cyst. Now, can you tell me what is the difference between simple and aneurysmal bone cyst? You can just see both the images. Simple bone cyst. See,
Simple is unilocular and aneurysmal is multilocular.
Not multilocular. It is multiple levels. Whenever you take the MRI, you see multiple fluid levels because it is filled with blood, right? But what is that important difference what you see? So I'll tell you this. So if you see the simple bone cyst, you see the expansion of it. It is within the bone. But can you see this one? It has come out of the cortex, right? It is expansile. So this word expansile is very, very important whenever you want to talk about your eccentric and expansile. So these are the terminologies which we use for both aneurysmal bone cyst and your GCT. But when you see simple bone cyst, it is not that expansile. It is not that eccentric. It is usually in the center within the limits of the bone cortex. Okay, can you identify it now clearly? Yes?
Yes, ma'am.
Very good. So this is simple bone cyst. This is ABC aneurysmal bone cyst. The important things you have to remember is metaphyseal origin and multiple air fluid levels. And where do you see this? You see on the MRI. And here you see multilocular. This is multilocular, right? So this is GCT multilocular, which will give you an appearance of a soap bubble appearance. And here the treatment is extended curettage. What you do is you completely scrape the bone. And then what you do, you have to put certain things, such as bone cement, right? Such as bone cement or any graft to bury that particular cavity. If you don't bury the cavity, there is high chances of recurrence. So you will put liquid nitrogen. So these are certain adjuvants which we use to kill the tumor, right? So liquid nitrogen, bone cement or muscle graft to cover the cavity. So that is about your GCT. And then what is this?
Enchondroma.
Very good. This is enchondroma. What do you mean by enchondroma? It is a cartilage tumor, right? Chondroma means cartilage. So this is cartilaginous tumor. And what is the specialty of it? It is usually seen in the small bones, such as your hand and feet bones. Hand and feet bones. So that you have to remember. So this is enchondroma. And what you see here, so if you see enchondroma, cartilaginous tumor, usually we see this patchy calcification here. Can you appreciate the patchy calcification? So slight areas of, whitish colors there. So that is the patchy calcification which we see usually in the cartilaginous tumor. And this is supposed to be enchondroma. And here the important thing what you have to remember is usually seen in small bones such as your hand and feet bones. Okay. So that is about the most of the benign tumors. Now coming to the malignant tumors. So these are some of the examples of the malignant tumors. So in malignant tumors, the first and foremost, most important tumor which you have to remember is this. So what do you think is this? Yes, very peculiar arrangement. Yes, I'm waiting for that. Very good. It is Ewing's sarcoma. Ewing's sarcoma, right? So how do you identify it as Ewing's? So bone is in the onion peel pattern.
Onion peel appearance.
Very good. Onion peel appearance. So what is this onion peel appearance? This is all about your
Ewing sarcoma.
Ewing sarcoma. So what is happening there? The periosteum is irritated and this is forming layers of the bone which appears as the onion peel, and this is called as Ewing sarcoma. And what is this? This is called hair on end appearance. Right? So these are the two important things which you have to remember. And what is the important things about Ewing sarcoma? If they want to ask about Ewing sarcoma, what will they put up in the question? So usually age group, right? So what is the age where do you see Ewing sarcoma? Yes?
5 to 10 years.
Yes, 4 to 8 years or 5 to 10 years, right? Usually in the first decade, that you can say it is in the first decade. And the next one is, what is so important, you have to remember about Ewing sarcoma. Whenever somebody says Ewing sarcoma, these are the important things which should strike. So first one is, patient will come with pain with the fever. So it will mimic like the infection. It will mimic the osteomyelitis because you see pain and fever. And one more important thing what you see is there will be a raised ESR and raised CRP also in case of Ewing sarcoma. So this is one of the most important and peculiar thing which you have to remember. Okay, one second. So this is one of the most important and peculiar thing you have to remember. What is it? The Ewing sarcoma has an ability to mimic the infection. So what the patient comes, he comes with the pain and then they'll have fever. And then whenever you go for investigation, there will be raised ESR, raised CRP. Okay. So now what you have to do? You have to properly evaluate. So what is the important, final diagnosis for Ewing's? So now we are going to take out a tissue and you'll go send it for
Biopsy.
Yeah, very good. Biopsy, and also for culture and sensitivity. You have to send, as I've told you, that this mimics the infection. So all the whatever oncology treatment you're giving to the patient, so all the specimens should be sent for biopsy, and they also should be sent for culture and sensitivity, right? So what do you see on the biopsy? So once you want to tell or confirm it as Ewing sarcoma, what do you see on the biopsy? Small, round, blue cells, right? So everything is blue in color, right? Everything is blue in color, which are very small, and this is a very peculiar feature again for Ewing sarcoma. So what they do, they give you the pathology picture, where maybe they will put this biopsy picture, and then they will give you the history, and then they will ask you which tumor is this. Okay, this is a small round blue cells which you see on the biopsy, and on the x-ray what do you see? You see the onion peel appearance and hair on end appearance. That is about your Ewing's sarcoma. Then what is this? The next one. Very important, very easy. Yes?
Osteosarcoma.
Yes, very good. This is your osteosarcoma. How did you identify this as your osteosarcoma? And this is one of the most important and most common malignant tumor, and it is usually seen in your second decade, right? And one more thing, Ewing's, I have forgot, this is seen in the diaphysis, right? Location wise, this is seen in the diaphysis, whereas your osteosarcoma location wise, it is seen in the metaphysis. So for oncology, what is very important?
Metaphysis.
Yes, metaphysis, very good. So malignant tumors, whenever you're dealing, what is the first criteria? You have to look for the age, then you have to look for the location, then your periosteal reaction. So these are the certain things which will help you to arrive at your diagnosis. So age, what we have seen for Ewing's is first decade, right? For osteosarcoma, it will be your second decade, and usually it arises in the metaphyseal, that is location, right? And what are the periosteal signs for osteosarcoma? Very important, related to sun.
Sunburst appearance.
Yes, it is called the sunburst appearance. And what is the one more triangle?
Codman triangle.
Very good. It is the Codman's triangle. Yes, very good. So now what do you think is the sunburst appearance? Why is this appearing as sunburst? So what you have to remember about the osteosarcoma, this is a very important tumor where bone is formed. That is osteoid forming tumor. So on the biopsy also you will see seams of osteoid. So there is a bone literally which is formed in the tumor. So these bones which is formed, the small, the reactions of the bone which are formed along the vessels, and if you remember, there are Sharpie's fibers. So what are these Sharpie's fibers? These are nothing but the attachments. These fibers, they get attached the bone to the periosteum. So these are called the Sharpie's fibers or the blood vessels which are present around the tumor. Whenever the bone is formed along these lines, it appears as the sunburst appearance. Okay, is that clear? And the elevation of the periosteum at one level, because of the tumor, there will be elevation of this periosteum, and this elevation of the periosteum will appear as a triangle, and this is called as the Codman's triangle. Okay, understood? Yes. So two important things which you have to remember of osteosarcoma: second decade, metaphyseal, and what are the periosteal reactions? Sunburst appearance and Codman's triangle. Nothing to by heart. We know why there is a sunburst appearance, and now we know why there is a Codman's triangle, right? And here in Ewing's, the periosteal reaction appears in the layers. Hence, it gives the onion peel appearance, right? So that is how you have to remember. And now what is this? Multiple punched out lesions in the skull. It is very, very important, and this is your medicine also.
Multiple myeloma.
Yes, this is multiple myeloma. And this is supposed to be one of the most common tumors which is seen in ortho after secondaries. Right, so first important tumor or first important related to oncology in ortho we see are the secondaries, right? After secondaries. And what is the age group for multiple myeloma? I think you know this better than me because you have already read in medicine. 60 years? Yes, age group. Am I right? So multiple myeloma is usually seen in the elderly, right? 60 years of age group. And what is that most important thing in multiple myeloma? What happens here? What are those proteins which are produced?
Protein.
Yes, those are the Ben Jones protein. So there is a problem in the which cells? Plasma cells?
Plasma cells.
Very
It's
good.
a cancer of plasma cells.
Very good. It is a cancer of plasma cells. So what actually plasma cells does to the body? What is the function of the plasma cells? Yes. They are responsible for producing the immunoglobulins, right? So these immunoglobulins are the defense mechanism for our body, right? So whenever we fight with infection, there will be this
Proteins, antibodies.
Immunoglobulins or antibodies, right? So whenever there is a tumor of this, there is a lot of abnormal immunoglobulins which are produced, and these are called the Ben Jones proteins, right? And so that is why the patient will end up with lot of infections because the immunoglobulins which are produced are not proper. They're all these immunoglobulins are all modified. They can't fight with these antibodies can't fight with the antigens which are entering the body. Hence the patient will end up with lot of infections, right? And then he will have all punched out lesions, and this will result in fractures, especially in the vertebrae, and he will have features of hypercalcemia. So there will be increased features of hypercalcemia, right? Hypercalcemia, such as renal stones, they will produce, they present with renal stones, right? So that is the some of the features of your plasmacytoma or your multiple myeloma. Is that clear?
Yes, ma'am.
Yes. Then what is this? After reading so much of oncology, they might just land up in this particular tumor for you. So this is what? Any guesses? This is called non-ossifying fibroma. This is not a tumor. This is just an incidental finding which is seen. Nothing to do with it. It will resolve on its own, right?
Ma'am, what are the patient complaints?
Patient complaints are nothing. Usually they don't come. This is an incidental finding. That means patient will come with some other findings. And when we take up the X-ray, you usually see or notice this type of picture, right? So this is non-ossifying fibroma. Patient will not come with any complaints. Almost he can complain with only a mild pain, probably. That also is not considered as pain, but usually they complain with pain. But this is an incidental finding. That means he comes with some other complaint, and when we take the X-ray, we find this finding. So that is why this is called an incidental finding, which is called as non-ossifying fibroma, and usually it resolves on its own, nothing to do with it. Okay, usually seen in the tibia bone. Okay.
Okay, ma'am.
Yes. And then what is this? If you can identify again, this is a CT scan of the vertebrae. And what you can see on the CT scan of the vertebrae? In one particular vertebrae?
Jail bar appearance.
Yes, it is the jail bar appearance. Seen it? What condition? Hemangioma. Yes, vertebral hemangioma. This is again an incidental finding. Usually patient will not have any complaints. He might come with some other pain, and when we take the X-ray, we find this hemangioma. And if you see, this is the sagittal section what I'm speaking about. When I say axial, what do you see? So now this is your vertebrae, and now I'm cutting the vertebrae like this. So what is this? Ah,
Polka.
very good. Excellent. This is the polka dot appearance. So these two are related to your hemangioma. So one is your gel bar appearance or corduroy appearance. Corduroy is what? It's a type of fabric where you can see the lines, right? Corduroy appearance. It is a type of fabric. And gel bar appearance and polka dot. Polka dot is usually we see on the axial section, right? So these are some of the important things which you have to remember regarding the hemangioma, non-ossifying fibroma and hemangioma. Is that clear? So now that completes your orthopedic oncology. Now let's have a quick review for your nerve injuries. So nerve injuries is also one of the most important topic, and IBQ is also common from this topic. And usually these are the images. I mean, these are like almost 95% of the images I have come up with. And so what you have to remember is there are three important nerves: median nerve, ulnar nerve, and radial nerve. Okay, as you all know. So median nerve is what it supplies? Quickly.
Lateral 3.5 of the fingers.
That is your sensations, right? So it usually supplies the flexors of the forearm. Yeah, flexors of the forearm, except there are two important exceptions of the flexors of the forearm which is not supplied by the median nerve. What are those? Quickly.
Adductor pollicis and
I'm talking about long flexors.
Flexor digitorum profundus.
Yes, that too, medial half of flexor digitorum profundus and one
Flexor digitorum longus.
more. Flexor carpi ulnaris.
Ulnaris.
Very good. You have to remember this. No going away from this. Okay. You have to remember median nerve and ulnar nerve will supply the flexors. Radial nerve will supply the extensors. Okay. This should be like integrated in your mind. Whenever somebody is talking about extensors of hand, or in that case upper limb, what is the answer? Supply of the extensor, all the extensors are supplied by
Radial nerve.
yes, no confusion. Radial nerve, no confusion. And somebody is talking about flexors. We have two groups, right? Superficial and deep flexors. And in that, what you have to remember, there are two important nerves. So one is the median nerve, the second one is the ulnar nerve.
Ulnar nerve.
Yes. So median nerve, it supplies all the flexors, all the long flexors of forearm, except medial half of flexor digitorum profundus and flexor carpi ulnaris.
Carpi ulnaris.
Yes. Then the ulnar nerve supplies your medial half of flexor digitorum profundus plus flexor carpi ulnaris. So this is about the forearm I'm talking about. And now coming to the hand. Hand, if you see, what are the intrinsic muscles of the hand? What are the 5 groups of intrinsic muscles of the hand?
Thenar muscle, hypothenar muscle.
Yes. So thenar, ulnar nerve supplies hypothenar. Then
Lumbricals.
yes, lumbricals. So first and second lumbricals are supplied by your median. Third and fourth lumbricals is by ulnar.
Ulnar nerve.
Then, so we have completed
Palmar
3. Very good. Palmar interosseous and
dorsal interosseous.
dorsal interosseous. That's it. This particular slide has to sit in your mind because again, this is an integration of anatomy and ortho. Okay. So this could be write your first question in the exam. So what are the muscle supply? Okay. So you have to be very, very clear. That is the thenar group of muscles and lumbricals. First and second are supplied by the median nerve, and other 3 groups. In the 5 groups, the hypothenar, the palmar interosseous and the dorsal interosseous are supplied by your ulnar nerve. So that is why ulnar nerve is called the, because it is supplying the fine muscles of the hand, right? It is supplying the fine muscles. So fine muscles, it is called as the
Musician stuff.
yes, musician's nerve. And whereas your median nerve is supplying the long flexors. Long flexors, it is called the Laborer's nerve. Laborer's nerve, because it is doing major action like you're lifting heavy weight, and this is your fine movement, that is your musician's nerve. Understood?
Yes, ma'am.
No confusion? And now, as Clara told us, the sensation. So when it comes to sensations, the median nerve supplies the 3.5 fingers. Okay? And the ulnar nerve?
First 1.5.
1.5. Which side of 1.5? Ring and little finger. So this is
ring
your,
and little.
yes, this is your thumb, index and middle finger.
Medial 1.5.
Yes. So this is by your median nerve. So that is why you have all this, right? Your benediction sign, your ape thumb deformity, your pointing index, all are related to your median nerve. So something related to these 3 fingers is median nerve, and something related to this, such as your claw hand, is your ulnar nerve. Is that clear, guys?
Yes, ma'am.
Yes, very good. Now putting up all this in the head, we'll answer this. So now I've told you the median nerve. So what is the first picture? Thumb in the same plane. Very good. This is called the ape thumb deformity. So why it is called the ape thumb? So ape,
Thenar muscle wasting.
huh?
Thenar muscle wasting.
Yeah, it is about the thenar muscles wasting. And what happens is, so actually the most important feature of the humans is the thumb is perpendicular, right? So in the apes, it will be in line with the others. So because of there is a wasting of the thenar muscles, there is no supply properly to the thenar muscle, it comes back to this position, which is called as the ape thumb deformity. Okay, then what is the next one?
Pen test.
Yeah, this is pen test. So what are we testing here? Again, the thenar group of muscles. Yes, especially the abductor pollicis. So here what we are doing, we are putting the pen, which is again perpendicular to your hand, and the patient has to touch with the tip. So this is called the pen test. If you see again the involvement of thumb. Thumb is related to median nerve, right? And then what is this?
Index.
What index?
Pointing index.
Pointing index. This is called the pointing index. Why there is a pointing index finger only?
It's for a flexor digitorum superficialis.
Yes, the flexor digitorum superficialis, especially the flexor digitorum superficialis of the index finger is independent. So usually what happens, the flexor digitorum superficialis will come like this and it splits like this, right? So now, especially for the index finger, it is mainly the FDS which has to work to flex the finger, right? So this is called the pointing index, especially seen in the median nerve palsies, and this is also called as the Ochsner's clasp deformity. Not to get confused, both are same. Ochsner's clasp deformity and pointing index, both are the same. And what is the next one? What is this? As I've told you, what is this?
Partial claw.
This is not partial claw hand. What is clawing? This is called the Pope sign. Pope sign or the benediction sign. Very good. So why this is not the claw hand? This is where you have to learn the basics, right? The concept comes here. So this could be a pop benediction or the pop sign. So sometimes we get confused with the claw hand. So what is actually clawing? Yes. So what is actually clawing? Clawing is hyperextension of the MCP and flexion of the IP. Can you see that? My hand is claw hand. So whenever what is seen in Pope sign, what we are seeing, there is a flexion of the MCP, right? Understood? Are you understanding?
Yes. Yes, ma'am.
Yes, very good. Now I'll show you the claw hand. So this is what?
Partial claw.
Yes, this is partial claw hand. So how are you telling? How are you telling this is partial claw hand? can see. Very good. Yes, you can see there is hyperextension of the MCP and flexion of the IP. This is what you have to remember.
IP.
Yes, hyperextension of MCP and flexion of IP. This is your claw hand. But what you see in the Pope's this thing, benediction sign, you see there is a complete flexion of MCP, right?
MCP, complete flexion of MCP.
Yes, that is how you have to differentiate. Don't get confused in the exam. Okay?
Okay, ma'am.
Good. Then what is this?
Book test.
Okay, the aside one.
Part test.
This is your card test. Very good. Card test is used for
Palmar introduction.
palmar introtia. And what is the action?
Adduction.
Adduction. Very good. And now what is this?
Book test.
Okay, book test. This is for?
Adductor policies.
Very good. So this is for your adductor pollicis. And now what is this adductor pollicis? Whenever the term pollicis comes, which group of muscle is this?
Adductor policy. It is thenar muscle.
Yes, this is a thenar group of muscle, but it is supplied by your ulnar nerve. So that is the exceptional.
Only one thenar nerve.
Very good.
Thenar muscle.
One thenar muscle. So I'm going to write again here. So this is an exception, which is very, very important. You have to remember. So that is your adductor pollicis, which is supplied by your ulnar nerve, hence the book test. And what is the sign called? It is called the Froment sign. Yes. What is this Froment sign? So adductor pollicis, what is the matlab adductor pollicis means you are adducting, right? So you're holding the book by adduction, right? But here if you see, this is completely adduction. But what is this? This is flexion. So whenever there is an ulnar nerve palsy, instead of adductor pollicis, the thumb goes into flexion. So flexor pollicis is used. So flexor pollicis is supplied by median nerve, right?
Flexor pollicis median nerve.
Yeah. So now this is called the Froment sign. So whenever you see flexion in the IP joint, this is called as Froment sign. Understood?
Yes, ma'am.
Yes. So that is your book test and card test. So whenever there is ulnar nerve palsy, what is the splint we use?
Knuckle blender.
Yeah, knuckle bender splint. So now you see the knuckle bender splint. What is the action of the splint? It is causing flexion of the MCP and yes, extension of your IP. So that is the action of your knuckle bender splint. Understood? So that is your ulnar palsy. Ulnar nerve palsy. So what you see the partial claw hand. Then we have card test, the book test, and the splint which is used is the knuckle bender splint. Is that clear?
Yes, ma'am.
Then this is your favorite. What is this?
Saturday night pulses.
Yes, this is your Saturday night palsy. Very good. What happens in the Saturday night? We go for binge drinking. So during that drink and all, what happens to the patient? He puts pressure
Compression
over
of the radial nerve.
Yeah, this compression. What is this called? This compression? Neuropraxia. Very good. Neuropraxia. What do you mean by neuropraxia? This is just a physiological conduction block. So the result is recovery is
100% reversible.
Yes, 100% reversible. So whenever there is a Saturday nerve palsy, the patient will land up in what?
Wrist drop.
Very good. Wrist drop. So what is this wrist drop? There is loss of extension. As we have discussed, the radial nerve is mainly for extensors, right?
Extension.
Right, extensors. So here there will be a drop in the wrist drop. This is called the wrist drop. And what is this? What is this fracture?
Radial nerve because shaft.
Because there is a shaft. This is humerus, right? So this is the humerus. And if you see specifically, this is the proximal humerus, middle humerus, distal humerus. So junction of the middle and the distal, there is a fracture, and there is a high chance of this fracture resulting in the wrist drop because there is a compression of the radial nerve. So here what happens, the radial nerve will pass like this, piercing the lateral intramuscular septum. So whenever this fracture occurs, there is a possibility of crushing of the radial nerve, again resulting in the wrist drop. So this is called as the Holstein-Lewis fracture.
Fracture.
Okay? Just repeat,
Yes,
which
ma'am.
fracture is this? Holstein-Lewis fracture. Yes, you have to.
Holstein-Lewis fracture.
Yes, you have to remember. So this wrist drop whenever is occurring, this is also a neuropraxia. And what is the treatment for this? What is this called?
Coca splint.
Yes, which cock-up splint. So what is the A? Static cock-up splint. B is dynamic cock-up splint. So there are two types of
Dynamic.
Yes, two types of cock-up splint. One is your static. The second one is your dynamic cock-up splint.
Dynamic Coca splint.
Why is the name dynamic given to it?
It's fully immobile.
Yes, because of the springs which are present here, you can move the fingers, right? So you can extend the fingers and then you can come to the neutral position. Because of that, this is called the dynamic cock-up splint. Here just we will put in the neutral position. There is no movement, there is no extension which is happening. That is the static. Clear? Yes. What is this sign?
Allen's test.
No, this is Tinel's sign. What is the Tinel sign? What is the Tinel sign? So whenever there is a nerve palsy, and especially in the neuropraxia, there is a recovery, right? As you told, there is a 100% recovery. And this recovery is usually from the proximal to distal, right? Is that clear? Proximal to distal. So if there is a cut here, if there is a cut here, the development or the treatment, I mean like the recovery is from proximal and it comes like this to the distal. Yeah. And now what is the Tinel sign? So what we do is we tap the nerve from the distal to the proximal. So at a particular area, whenever there is a recovery of the nerve or the fibers have been formed there, you can hear the sensations. The patient will have this tingling effect over the particular nerve distribution. So for example, if it is a median nerve palsy and we tap in the area of the median nerve palsy like this, we just give just a tap like this. So you can see there is a sensation, that is tingling, numbness over that particular 3.5 fingers, right? So that is called your Tinel sign. So whenever there is Tinel signs positive, that means recovery is happening in that particular nerve. Clear? So this is an example of the Tinel sign. Okay. Then what is this test? This is lateral epicondyle. And now the examiner is asking the patient to extend the wrist. So what is this test? For lateral epicondylitis, which is also called as? Yes, correct. Tennis elbow. What is this test? Name of the test? Yes, Clara?
Cozen test.
Yes, Cozen's test. Very good.
Cozen test.
Yes, this is called the Cozen's test. Cozen's test is whenever the patient is complaining about lateral epicondylitis. And here the question this time they can ask you, what is the tendon which is involved in lateral epicondylitis, very important muscle or tendon. It is extensor carpi radialis. Carpi radialis brevis. Okay, this you have to remember because this could be, yes, this could be the potential question because they usually ask about the lateral epicondylitis, tennis elbow, Cosen's test. So they can now ask you about the which of the following muscle is mostly involved in tennis elbow. So the answer here is
Tennis elbow.
yes, extensor
Carpi radialis
brevis.
Carpi radialis brevis.
Brevis, very good. And what is this test?
Reverse Cosen test.
Reverse Cosen test. Okay. So now what are you observing here? There are two tendons which are seen, right? And now the patient is forming a fist and he's trying to flex it, right? Like this. So this is your 𝐷𝐄𝐝 tenosynovitis. So what is this 𝐷𝐄𝐝 all about? So if you remember the extensors of the hand, right? So they are placed in 6 compartments, right? There are 6 compartments where the extensors are placed. In that, we are worried about the first compartment muscles. Those are APL, EPB. Abductor pollicis longus, extensor pollicis brevis. You have to remember. Very good. So now you see there are 2 tendons which are there, and now the patient is forming a fist like this and trying to flex and extend, right, against the resistance. So whenever he's doing that, he's having pain. So this tells you about the 𝐷𝐄𝐝 tenosynovitis.
Sinusitis.
What is what is the importance of the tenosynovitis? That means it is the tendon sheath which is covering the tendon that is inflamed. Understood? Not the tendon. Tenosynovitis. So the synovium which is covering the tendon is inflamed. Hence this is called as tenosynovitis. Especially which tendons? What are the 2 tendons?
Extensor pollicis brevis and debtor pollicis longus.
APL, EPB. Okay, very important. And what is the name of this test? Finkelstein's test. Finkelstein's test. Okay. So this is your Cosen's test. This is your Finkelstein's test. This is your Tinel's sign. Clear, everybody?
Yes, ma'am.
Yes. And now this is the sensations which we have already discussed. So this is the ulnar nerve. I have told you the 1.5. And this is your median nerve, the 3.5. And what about the radial nerve? It is only the small area. This is the dorsal web space which is supplied by the radial nerve. Okay?
Yeah, ma'am.
Yes. And now, so having read about so much of the upper limb, so what is the one important lower limb nerve which you have to remember? The CPN, common peroneal nerve, right? What is the importance of this? It supplies the dorsiflexors, right, of the foot and the everters. Okay, so what will happen whenever there is damage of the CPN? It will result in
foot erosion.
Yeah, it will result in foot drop. So foot drop is nothing but like your wrist drop, you know. It is like the wrist drop where the extensors are not working. Here also the dorsiflexors are not working. In foot it is dorsiflexion and plantar flexion, right? So that is why no dorsiflexion, there is a foot drop. So what is the gait which you expect in the foot drop?
High stepping gait or foot drop.
Yes, high stepping gait. Why it is a high stepping gait? Because the patient cannot dorsiflex, right? He cannot pull his foot up and then put this step. So that is why what you do, he moves entire knee. So that is why this is called as the high stepping gait. And what is the splint which we use? Foot drop splint. So this is your foot drop splint. So what is this? This is the foot orthosis and putting your ankle in the neutral position. So this is your foot drop splint. Clear? And what is the importance of the CPN? The CPN has it neck of the fibula. It revolves around it turns over the neck of the fibula. So whenever there is a fracture of the neck of the fibula, you have to check for the foot drop. And this was asked again in the exam. Yeah, they just have pointed out the nerve and they have asked what this leads to. Whenever there is a damage to this particular nerve, it leads to your foot drop, right? So this was asked
Yes, ma'am.
in the exam. Then what is this?
Regimental sign.
Yes, regimental sign. Which nerve?
Axillary nerve.
Which muscle it supplies?
Deltoid teres minor.
Yes, it supplies deltoid and your teres minor. And deltoid is responsible for what? Action of the deltoid
Abduction.
muscle? Yes.
Abduction 15 to 90 degree.
Yes, it is actually deltoid is responsible for all the actions except adduction, but especially we will remember it as abduction. Then teres minor?
Teres minor, rotator cuff.
Yeah, rotator cuff only. What is the action of it? Teres minor cuff. External? It is external rotation. And this is a small patch of the sensations it supplies, and this is called the regimental badge area. So this is about your axillary nerve, right? And which traumatic condition will result in palsy of this axillary nerve? Most common. When do you suspect the axillary nerve injury? In which traumatic condition? Anterior, shoulder
dislocation.
Yes, very good. So they can ask you this way also. So they can put up this image and they can ask you what is the most common injury? It is the anterior shoulder dislocation. Very good. Okay. And then what is this? These are two brachial plexus injury. Okay, the first one is? Yes, it is the 𝐒𝐻𝐝 palsy. The second one is? Yes, 𝐒𝐿𝐾𝐝 palsy. So what is the importance of 𝐒𝐻𝐝 palsy? This is the upper trunk, right?
Yeah.
That is the 𝐒𝐻𝐝 point, if you remember. And again, the problem here is which nerves get involved?
Arm is adducted and medially rotated.
Yes. So there is an adduction, internal rotation of the shoulder with elbow, extension and?
Forearm pronated.
Very good.
Just flex.
Yes. Adduction, medial rotation. Elbow you have, there is an extension of the elbow plus pronation. So again, here we know the adduction is happening because which nerve is getting damaged? Axillary again.
Axillary nerve.
Yes, axillary nerve plus your musculocutaneous nerve.
And suprascapular nerve.
Yeah, axillary nerve, suprascapular and your musculocutaneous. So whenever there is an axillary nerve damage, what happens? There is a loss of abduction. So the shoulder goes into adduction, internal rotation, and because of the musculocutaneous, which is responsible for flexion and supination, now the limb goes into extension and pronation. So what is the commonly this is called as? Policeman
tip hand, waiter's tip hand.
Deformity. Yeah. Policeman tip or waiter's tip deformity. Right? And what about clump case? Clump case where which trunk is involved? Lower trunk.
Hyperabduction of arm.
Yeah, this is C8 and T1. So C8 and T1, which nerve?
Ulnar and median nerve.
Yes, ulnar nerve. So whenever there is ulnar nerve and median nerve is involved, what happens? What deformity we see?
Claw hand.
Yes, claw hand. Very good. So these are the two important things which you have to remember. So these are the brachial plexus. One is your Erb's palsy. The second one is clump case. And in the clump case, we usually see the claw hand. It could be a partial or a complete claw hand. In the Erbs, we see polysmentic deformity. And what is the splint we use for brachial plexus injury? What is the splint called? Aeroplane splint.
Aeroplane splint.
Yes, aeroplane splint. What is the, what is the position of this? If you see, the shoulder now is put in abduction.
Abduction.
Yes, and elbow in flexion, right? So that is how we treat it. So mainly for the brachial plexus injury, we use the splint, which is called as the aeroplane splint. Okay, is that clear? So that completes the nerve injuries. Now let's move on to the joint disorders. So joint disorders, mostly we have two important things you have to differentiate in the exam. So one is your osteoarthritis. The second one is your rheumatoid arthritis, right? So osteoarthritis is mainly about the wear and tear mechanism, right? So there will be wear and tear mechanism, that is degenerative. As we use, the joints get damaged. But what is inflammation? This is because of your body.
Autoantibody.
Yes, it is producing the autoantibodies and causing destruction of your joint. So what are the peculiar features of your rheumatoid arthritis? What do you see? Usually it is bilateral, right? Bilateral. And what is the second peculiar thing? It is usually
symmetrical.
Very good, symmetrical. And what you specifically see is the bone erosions, right? So these are the three important things which you have to remember. It is usually bilateral, symmetrical, bone erosions, and one more important thing, there is an involvement of the small joints, right? Especially your MCP joints are usually involved, right? Yes. So this is about the rheumatoid arthritis. When coming to osteoarthritis, what do you usually see? What are the important things? So this could be unilateral, not symmetrical. What is the most important thing? What we see? Bony osteophytes. Yes, you see bony osteophytes, and usually the medial joint space is involved. Here both the joint spaces in case of rheumatoid, but in case of osteoarthritis, it is mainly the medial joint space because this is the weight-bearing space, right? So because it is a wear and tear mechanism, because of the weight bearing, we get the medial joint space which is usually involved here. Okay? And what is the most important thing I want you all to remember is, whenever they talk about osteophytes, this is mainly they're talking about osteoarthritis. Whenever they talk about bony erosions, they're mainly talking about your rheumatoid arthritis. Is that clear? So these are the osteophytes, what I was talking about. So you can see these are the subchondral cysts. These are called the subchondral. So there will be a joint space narrowing and presence of subchondral cysts and presence of your osteophytes. So that is about your osteoarthritis. And what are these two important nodes which you have to remember, which are seen usually in your IP joints, right? So Boucher's nodes and Hurbiden's nodes, right? How do you remember? HD and BP. What is HD? Hurbiden's nodes are usually seen in the distal interpharyngeal joints. And BP, Boucher's nodes, are usually seen in the PIP, that is proximal interpharyngeal joints. Clear?
Yes, ma'am.
Yes. And then what are these? In case of rheumatoid arthritis, what is most important thing which you have to remember? That is your deformities, right? So there are multiple deformities which you can see, and in that, what is the most important two? One is your swan neck. Second one is botaniers. So these are two important things which you have to remember. One is your swan neck deformity and the botaniers deformity. So what is swan neck? Swan neck. This is swan neck. So you see flexion in the DIP. Just remember FD. Fixed deposit. Right? So flexion in the DIP is your swan neck deformity. That's it. Don't get confused. Flexion in the DIP is your swan neck deformity. So whenever there's a flexion in DIP, there will be extension in the PIP. Right? So it's exactly is opposite for your botaniers deformity. Right? Understood?
Yes.
So this is your swan neck. So whenever you see flexion in the DIP, there will be extension in the PIP. Botaniers is exactly opposite. There will be flexion in the PIP and extension in the DIP. Okay? So these are the various deformities. And you will see there will be ulnar deviation also because of the joint erosions. The cartilage is completely eroded. So there will be ulnar deviation. So these are multiple deformities which you see. The botaniers, the swan neck, the ulnar deviation, the Z deformity of the thumb. So these are the deformities which we see in the rheumatoid arthritis. And two important notes, Bouchards and Haberdens we see in the osteoarthritis. Okay. What is the treatment for both of this? End stage. So usually they go for total knee replacement, right? So what happens in the total knee replacement? They're completely cutting out the femoral part, the tibia part, and now they are replacing it with the prosthesis. So this is the prosthesis where we have the femoral component, the tibial component, and there will be a poly in between them for the ease of the movement, that is flexion and the extension. Okay. So this is about the joint disorders. Okay, guys? Clear?
Yes, ma'am.
Any confusion? Anything you want me to repeat?
No, ma'am.
Okay. Moving on to the next one. This is very, 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 very important. I don't know how many stars you want to put, but very, very important. Let us discuss about this. So what is this? So many signs together. This is?
Ankylosing spondylitis.
Yes, this is ankylosing spondylitis. So what is ankylosing spondylitis? It is a condition which is usually seen in the
Sacroiliac.
huh?
Seen in the sacroiliac joint, spine and hip.
Yes, it is an axial joint involvement, axial spondyloarthropathy, the name given to it is. That means it is usually seen in the axial skeleton, and in that axial skeleton especially it is seen in the sacroiliac joint, right? And this is usually seen in the young males, and it is associated with HLA-B27. Okay, and how the patient presents
With backache.
yes, stiffness of the back pain, especially in the where during the morning times, right? Stiffness in morning stiffness. So usually whenever something is inflammatory, it is usually seen in the morning. Something is degenerative, it is usually seen in the evening. Why? So again,
ma'am, can I say once again?
So whenever
Can you repeat once again?
yeah, whenever something,
No, the last point.
yeah, whenever something is inflammatory in origin, usually we tend to observe that in the morning time, such as morning stiffness. In case of your rheumatoid arthritis also, there will be morning.
During evening, the muscles are relaxed, so it may cause more pain.
So what happens is whenever we are on the rest, so for example in rheumatoid arthritis we take rest the entire night, right? So now what happens, all your autoimmune bodies, all your inflammatory products, they get accumulated in the joint. So as soon as they get up, they will have pain because they are in rest and all your inflammatory products got accumulated. And over a period of time, as you start moving the joints, as you start working the joints, the products usually get flushed out, and then you will have decrease in the pain. Similarly, in the SI joints also, like your morning stiffness. Whereas in the degeneration, as we use the body, as we use the joint, wear and tear mechanism sets in, and usually the patient will have complaints in the evening time. Okay, is that clear?
Yes, sir.
Yeah, so that is about the inflammation. So patient comes with the pain usually in the back, SI joints, and they usually tell us the pain is worse during morning times. Understood? And what you have to remember here is young males. So usually males gets affected. And what is this test? Faber test is for testing your SI joints, right? So putting the limb in flexion, abduction, and external rotation. And when you distract the ligaments like that, then you will have pain. So this is the test for your SI joints, that is Faber. And what is this X-ray feature? This has been asked in the exam.
Bamboo spine.
Bamboo spine.
नहीं, ये dagger sign है. So you see, what happens in the ankylosing spondylitis is there will be calcification. Calcification of your posterior longitudinal ligament. This will appear as the dagger sign. You see, there is only calcification here, right? So this is appearing like this. So this is called the what sign? Dagger sign. Yes. And what is this?
Bamboo spine.
Why?
Bamboo spine.
Yeah, this is bamboo spine. Why this is called bamboo spine? Reason behind it? So again,
Squaring effective.
yeah, again there will be formation of the osteophytes, and but here this is called as syndesmophyte. So what is a syndesmophyte? This is, if you see, there is a calcification again at the end of the vertebrae like this, right? And what happens over a period of time, because of the multiple syndesmophytes which is formed, all the vertebrae will get fused, and which will result in a single unit which is called as your bamboo spine. Is that clear? So two important features. One is your dagger sign. The second one is your bamboo spine. Here there is nothing much to remember. This is only the haziness of your SI joint which I want to show you. Right? So this is just the haziness of SI joints, or there is a decreased space in the SI joints. That is your sacroiliac joints which are involved. Right? And what is this test? This is a test for flexion of the spine. To understand the flexion of the spine, the name given to this is Schauber's test. Okay. So what is the Schauber's test? So now what we do here is we will identify a point here. Probably this is the dimple of the Venus, which we say just a depression over the back. And now you take 15 centimeters above it, right? And now you ask the patient to bend. So usually what happened, it has to increase, right? But in case of your ankylosing spondylitis, because there is a restriction in the flexion of the spine, there will be decrease, or there will be same point. There will be no increase in the length. So that is why this is called as the Schauber's test. Okay. Understood, guys?
Yes, ma'am.
Good. So that is about your ankylosing spondylitis. So some of the important images which they can ask you again. So this is the psoriasis. What is the peculiar feature of the psoriasis? What joint is involved usually?
Distal interphalangeal.
Yes, distal interphalangeal joint, that is involved. And what is the appearance which we see on the X-ray? Pencil cup deformity. Very good. Pencil cup deformity. What is the criteria which is usually used in your psoriasis? Casper criteria. Casper criteria. This you have to remember. And what is actually psoriasis? It is again an inflammatory disorder, right? Autoimmune bodies, which will end up with the skin lesions, and whenever they involve the nails, nail dystrophy is usually seen, and this nails associated with your distal interpharyngeal joint. So that is your psoriatic arthritis. And this is also sometimes very, very debilitating, which is also called as arthritis mutilans. That means there will be complete destruction of the joints. So that is called as arthritis mutilans. Okay?
Yes, ma'am.
Yes. And what is this? If you see the notch here, so this is the notch, intercondylar notch, right? So there is a widening of the intercondylar notch. Where you see this? Hemophilic arthropathy. So whenever the patient presents with hemophilia, because of the destruction of the cartilage there, which will result in the arthropathy, you will see there is a widening of the intercondylar notch. Right?
Yes, ma'am.
So only these two you have to remember. So one is the widening of the intercondylar notch, and usually this is seen in the knee joint. Hemophilia, usually the patient presents with the knee joint, and you already know this is because of the clotting factor, especially seen in the males, right? Right. And what is this?
Is it Asok syndrome?
Which one?
Masusi?
No?
This is gouty arthritis. This is gouty arthritis, where there will be again because of the what? Gout is because of increase in the serum?
Uric acid.
Serum uric acid. So whenever there is an increase in the serum uric acid, what happens to the joint? The uric acid get crystallized, right? So they form what crystals?
Monosodium urate crystal.
Monosodium urate crystals, which are negatively birefringent. Okay? On the polarized right, we see it as negatively birefringent. Right? And usually which will involve the first MTP, metatarsal joint, right? Metatarsopharyngeal joint, first MTP, and usually males and
Who is ready test, alcohol and red meat test.
yes, alcoholics. And if it is females, they usually with diuretics, right? Females on diuretics. So whenever they have, this kidney problem, they will result in increase in the uric acid. So they are crystallized in presence of monosodium urate crystals. Okay? Which shape they are?
Needle shape.
Yes, needle shaped. Why I'm asking this? What is the other shaped where we see rhomboid? Which condition is that? That is pseudo gout. That is calcium pyroxy crystals which get deposited. Calcium pyrophosphate deposits. These are rhomboid shape. Okay? And this is also usually seen in the knee joint. Most commonly it is seen in the knee joint. Okay? So that is about the gouty arthritis. And finally, what is this? Complete sclerosis. And usually we see in the teeth, yellowish discoloration of the teeth. This is fluorosis.
Fluorosis.
Yes, fluorosis. What is fluorosis? Now what happens is there is a formation of calcium fluoride crystals, and these are very much reluctant to the resorption. Resorption means the bone is a dynamic state, right? So there will be formation of the bone and resorption of the bone. Here, because of the accumulation of the calcium fluoride, because of excessive fluoride content in the blood, this is not resorbed. That means they appear dense and sclerotic like the X-ray. And you can see there is an yellowish discoloration of the enamel, right? So this is usually prevalent in certain areas in Andhra Pradesh, I mean, in Telangana now it is Nalgonda, where we prevalently seen, and some areas of the northern countries, North India also, you see this condition which is called as fluorosis. Okay, you will see yellowish discoloration of the enamel with the formation of calcium fluoride, where the resorption is inhibited. Hence, it appears as a dense sclerotic bone. Okay.
Yes, ma'am.
Okay. Now, this two very, very important. What are this?
Rickets.
Yes. What are these three things which we see in the rickets?
It's
Cupping, flying, spraying.
Yes, cupping, spraying, and splaying, right? Yes. So now, what is actually rickets? There is a decrease
Vitamin
in
D
the
deficiency.
vitamin D. Very good. So what
In
is
children.
in children? So what is the importance of the vitamin D? It is mainly responsible for the mineralization. That is the word which you have to remember. So what happens is bone is formed. Bone is absolutely normal. So bone is two components, that is organic and inorganic. So organic mein what will have? You will have the collagen. So here the collagen is normal. But inorganic, that is calcium and phosphorus, are the minerals which will give strength to the bone. So whenever there is vitamin D deficiency, this vitamin D is responsible for absorption of the calcium, right? So because of decrease in vitamin D, there will be decrease in the calcium levels which gets deposited on the bone. Hence the bone becomes weak, right? So there will be demineralization of the bone. Understood? And what happens to this? This demineralization of the bone usually we see near the growth plate. So this growth plate is nothing but at the region of the metaphysis, right? So there near the metaphysis, what you see is accumulation here. There will be accumulation of multiple cartilage cells. So these multiple cartilage cells are not ossified because there is no calcium and phosphorus. Hence you see this widening of the metaphysis. Understood? So this is the epiphysis, this is the metaphysis. So between epi and meta, you have the growth plate. So in the growth plate, what you see, there is an accumulation of the multiple cartilage cells. Hence, there will be widening of the growth plate, right? So that is your cupping. So because of that, it appears as a cup-like shaped. And what is fraying? Fraying is all this extra, which is not very clear. So you can see some like this. These are called the fraying. And these extensions at the end, these are called the splaying. Understood? So these are usually seen in the wrist joint. So we take the X-ray of the wrist joint. Some disturbance from Rishabha. So usually we take the X-ray of the wrist joint. Guys, put your speakers on mute. I want speakers on the mute. Okay, so we take this and then we see these three things. That is your I want all these speakers on mute for some time. Yes. So we see these three, that is cupping, fraying, and splaying, right? Okay. Yeah. So now these are three important things: cupping, fraying, and splaying, which we usually see in the rickets. And what is the one more thing which we see in the rickets? The deformities, right? So deformities. What is that important deformities? That is your
Varum.
Yeah, genu varum. And rickets is based upon your age of the group. If it is an infant who's having rickets, you see the ping pong appearance, you know, all those ping pong ball appearance in case of infants. And then as they grow up, you see there is a delayed closure of the fontanelles. And then as again he grows up, so what you see? Harrison's groove. What is Harrison's groove? Harrison's groove, pigeon chest.
Under the ribs, diaphragm.
Diaphragm gets retracted. So here the diaphragm gets retracted. So this is called the Harrison's groove. And what is the appearance of the costochondral junction? What is that called?
Rachitic rosary.
Yeah, rachitic rosary. Very good. Rachitic rosary. So they are appears as the rachitic rosary. So these are certain things which we see in case of the ricket. So deformity is what you have to remember mainly. And then these are certain things like your Harrison's groove, the pigeon chest appearance, the rachitic rosary. Right? And when coming to scurvy. So this is scurvy. In scurvy, what happens? What is the problem in the scurvy? There is a deficiency of
Vitamin C.
vitamin C. What is the role of vitamin C in case of your bones?
Occurred collagen and hydroxylation of proline and lysine.
Yeah, there is mainly cross-linking of the collagen. So this cross-linking of the collagen is depending on the vitamin C. So whenever there is a decrease in the vitamin C, there is a deficiency of the vitamin C, the collagen becomes weak. So here this is an organic component, right? I've told you already. So here there is the mineral component which is decreased. Here the organic component decreased. This decreased. But the calcium and the phosphorus. So the mineral content is good. Right? So whenever there is increase in the calcium and phosphorus, you can see something as white. So that is why you see this as the dense zone of calcifications. Understood?
Yes, ma'am.
So whereas in rickets, because of the absence of the calcium, you see everything as a dark, like cupping, fraying and splaying. These are dark. And here you see something as white. So this is like the ring epiphysis. What is ring epiphysis? So Wimberger's sign, there is a calcification which is occurring around the epiphysis. You will see there is an increased calcification again in the metaphyseal, that is provisional calcification, which is called as the dense zone. Right? That is called the white line of Frankel. Okay, and not to forget that there will be subperiosteal hemorrhages. So there will be bleeding gums with the subperiosteal hemorrhages, right? So this is about the rickets. So rickets, what you have to remember is there will be calcifications, right? So because the calcium and phosphorus are normal here, you will see white ring epiphysis, white line of Frankel, and the extensions again, these are called the Pelkin spur, and some areas occurs as the
Subperiosteal hemorrhage.
Yes, subperiosteal hemorrhage and your scorbetic zone. Scorbetic zone is this area, this particular area below the white line of Frankel. This is called the scorbetic zone. Is that clear?
Yes, ma'am.
Yes, so that is about your rickets and the scurvy, not to get confused in the exam, okay? And what is that disease where both vitamin C and D are defective? This has been asked in the exam. This is a biochemistry question. Both the deficiencies, C and D, this is called as the Barton's disease, okay?
Barton disease.
Yeah, remember, this has been asked directly. Vitamin C plus vitamin E deficiency together is called as Barton's disease. Okay, this is a straightforward question which has been asked in the exam. Clear, guys?
Yes, ma'am.
Okay, now let's enter into the spine. Is it boring?
No, ma'am.
Thank you.
It's quite interesting.
It's quite interesting.
The integrations are quite interesting.
Okay, fine.
No, actually, anatomy and orthopedics are integrated together.
Yeah, yes. Okay, I'm happy that you're finding it interesting. Okay, now let us learn little bit of spine. Very, very important. The first and foremost thing which is important in spine is scoliosis, right? And this has been asked in the exam. What is scoliosis? It is sideward bending of the spine. So this spine, usually we have lordosis, right? You remember spine is a curvaceous structure where you have cervical lordosis, thoracic kyphosis, lumbar lordosis. So this is a normal representation of the spine. But whenever there is some problem in the spine, it can bend sideward or forward. So the forward bending is called as your kyphosis. The sideward bending is called your scoliosis. So remember, S side, S scoliosis. Understood? Now you can see in this particular X-ray, this is your scoliosis. The spine usually has to be straight, which is not straight here. And now what is important for us from the exam point of view? This is called the 𝐒𝐄𝐝's angle. So what is a 𝐒𝐄𝐝's angle? So here, whenever you see there is a bend, yeah, this was
Angle of curvature.
yeah, angle of curvature. So here you are seeing a bend here. So what happens is you have to identify the apex vertebrae. So this is the, I have identified this as the apex vertebrae. So how do I identify? You will see the vertebrae, and usually if both the vertebral end plates, like you see on the this is the anterior and this is the posterior. So this and this has to be of the same height. So that is called the apex vertebrae on the both the sides, right? So this is one apex vertebrae, this one apex vertebrae. And now what you do, you draw a line along the upper end plate of the upper side and lower end plate of the lower vertebrae. And now you draw perpendiculars to this particular vertebral lines. And this is called the 𝐒𝐄𝐝's angle, right? This is called the 𝐒𝐄𝐝's angle or your scoliotic angle. Understood how we are drawing the 𝐒𝐝's angle?
Yes, ma'am.
So first you have to identify both the vertebrae, upper and the lower, and here for the upper end plate and this for the lower end plate, you will draw the lines and then draw perpendiculars to it. It is called the 𝐒𝐄𝐝's angle. So why do you want to identify the 𝐒𝐄𝐝's angle? So based on that, you will decide the treatment. So if the 𝐒𝐝's angle is more than 60 degrees, so you go for surgery, right? And if it is somewhere 20 to 40, then you can use the orthotics. If it is less than 20, it should be less than 20, you will go for observation, right? Understood? So that is why you will identify the 𝐒𝐝's angle. So first,
Can you explain that 40 degree once again?
okay, so 20 degrees, if it is less than 20 degrees, you can still put the patient under observation, okay?
Okay.
And if it is 20 to 40 degrees, what you do is you use the orthosis. So what is this orthosis? If it is more than 40, you go for surgery.
Surgery.
Okay. So now what are the orthoses? So there are two important orthoses you have to remember. That is your Milwaukee brace. Okay. And the second
Milwaukee
one is
brace.
your Boston brace. So these are the two important orthoses which we use for scoliosis. So one is Milwaukee's brace. The second one is your Boston's brace. Boston's brace, if you see, it is like a tight structure. Like it is only up to the thoracic region, tight structure. Milwaukee brace is extending up to your cervical level. This you have to remember. They will ask in the exam. Milwaukee brace and the Boston brace. Okay. So this is your 𝐒𝐝's angle for scoliosis and this is your Milwaukee brace. Then what is this? This is called the research sign. They have been not asked this. So there is a high chance of they might ask this here. So what is research sign? This is iliac apophysis. Not epiphysis, apophysis. So what happens is scoliosis, in scoliosis as we grow, it can be congenital, right? So it can appear at any age. So usually we treat the patient once the growth phase is completed. Because before completion of the growth phase, if you treat it, there is a high chance of recurrence. So that is why you see that the patient growth phase is completed. So how do you identify whether the patient has attained the growth phase or not? So we'll take the help of research sign. That is your iliac apophysis. So this is just stage 1. If it is from here to here, stage 1. If it has reached stage 2, This is 3 and 4. And if it is completely, apophysis is completely calcified, then we call it as stage 5. Understood? So this is called the research sign. So this, based upon this, you will decide whether the patient is ready for surgery or not. Clear, guys?
Yes, ma'am.
Yes, Cobb's angle, very, very important. Research sign, not very important, but it could be a potential question. Again, Milwaukee is important. Boston is okay. Okay?
Yes, ma'am.
That is about scoliosis. And then these are some of the orthotics which they can ask you. So what is the first one? Just identify, that's it. This is hollow vest. So completely the cervical is enclosed and there is a pins which are attached to the head here. So this is called the hollow vest. Okay. Just remember there is a head ring with the pins, that is hollow vest. Then what is this? This is 4-post collar. You can see there are 4 posts here. 1, 2, 3, 4. This is 4-post collar. Okay, this is hollow vest, 4-post collar. This is 𝐒𝐿. Sternum, occiput, mandible. All the 3 are immobilized. So this is your sternum, occiput, and mandible. 𝐒𝐿. Okay, this is your 𝐒𝐿 brace. Okay, and what is this? So even if you forget all the 3, this is very, very important. What is this brace? This is your Taylor's brace. Taylor's brace, and mostly used for your tuberculosis. So if you see, it is a thoracic orthosis. So all these are almost cervical, right? So this one, all the 3 are cervical. But here, if you see, this is a thoracic and the lumbar corset. So it is enclosing Taylor's brace. It is enclosing both your thoracic and your lumbar. Okay.
Lumbar.
So this is Taylor's brace. Usually we use it in the
TB.
yes, tuberculosis. Very good, excellent. And then what is this? Very easy. It is nothing but a cervical collar, but it is a hard cervical collar. Where we use it, it is used in the trauma. So whenever you suspect a cervical injury, when the patient is in your casualty, you put this brace, we put this cervical collar for immobilizing the cervical spine, that is stabilization of the cervical spine. This is just a hard collar. What is this? The next one? What is this?
Thompson's.
Thompson nahi, Thomas. Thompson is a test.
Thomas splint.
This is a Thomas splint. So where we use this Thomas splint? Usually it was used in World War II for tuberculosis, but now we are using it for femur fractures. Okay, this was used during World War II in tuberculosis, for tuberculosis, but now we use for femur fractures. So what is there in this? What are the contents? There is a ring, right? And there are 2 rods here. One is external, one is outer and inner. So outer, how you identify? Inner, how you identify? Outer, there is a, like this one, groove is there. This is to accommodate your greater trochanter. Okay? And these 2 rods are connected by W-shaped structure. And what you do, you will take the bandage and then you will prepare the Thomas splint like this. You put the bandage all over, and over this bandage you will place the limb, right? And now you will use for shifting of the patient, right? So this is mainly used for immobilization. Understood?
Yes, ma'am.
Femur fractures. And then what is this? This has been asked in the exam. FMGE. Recently they have asked. What is this? This is a bowler brown splint.
Stimson.
This is BB splint. Where this is used, BB splint? Kaha? Yes, come on, faster. Skeletal traction. What is skeletal traction? Skeletal traction, what we'll do? We put a pin. So now, for example, if the patient is having femur fracture, let us assume the patient is having femur fracture. Now, what you do, this is your tibia. So from the tibia, upper tibia, what you do is you put a pin. So this pin is called the Steeman's pin. Okay? So
Okay,
once you put the pin here, now what you do, you will put the weight to that particular pin. So this is the
Stimson spin.
Steeman's pin, not Stimson. Steeman's pin, yeah, Steeman's pin, right? And then this is the pulley which we use. So this particular pulley we use, and we put the weight to this. Okay. So that is how you prepare the patient. So you put the Steeman's pin. So this is the limb of the patient, and now you put the Steeman's pin and you attach device to it, which is U-shaped structure, and then you hang this to a pulley. So this is entire thing is called the Bowler Brown splint or BB splint. Okay.
Yes, ma'am.
Yes, this you have to remember. This has been asked in the recent exam. Okay, now coming to this two. What are these two?
Fracture of the neck of the
Neck of the
Humerus.
humerus, right? So, but is the bone normal? Bone is appearing normal to you, or there is some abnormality in the bone?
Some lesion.
Yeah, there is some lesion in the bone. So whenever there is a lesion in the bone and you see a fracture, what is that fracture called?
Thoracic fracture.
Yeah, this is called a pathological fracture. So bone is abnormal. So whenever bone is abnormal, even slight stress also will result in fracture. So this is called the pathological fracture. What is the criteria which we use in pathological fracture? This is an important question. Merrill's criteria.
Merrill's criteria.
Yeah, what is the criteria for fracture fixation? So whether you have to fix the fracture or not depends upon your Merrill's criteria. Okay. So this is the pathological fracture, and what you have to remember is the bone is abnormal here. So even small amount of stress also will result in fracture. Okay. Then what is this? So here the bone is normal, but repetitive stress will result in fracture. What is that repetitive stress? For example, in the shoulders,
Second metatarsal.
second metatarsal. Very good. So this is called the March fracture, and this is an example of stress fracture, right? So this is a pathological fracture. This is a stress fracture. So stress fracture, which is also called as your March fracture, usually seen in the second metatarsal. So this is your second metatarsal. And usually the patient complains with pain, and on the X-ray you see there is a callus formation. Right?
Callus formation.
Yeah, callus formation is seen. Yeah. This is called the stress fracture or the March fracture. Remember, one is a pathological fracture. You will see the bone is abnormal already. So even the smallest amount of stress also will result in fracture. Whereas in stress fracture, the bone is normal. So here what happens? You have to repeatedly small stresses will result in the fracture. Okay. Now what are these two? So these are complications of the fracture. So what is the first one? First complication of the fracture. So there has been fracture, but if you see the ends are fused. So what is this called?
Malunion.
Huh?
Malunion.
This is called non-union. There is no union, right? You can see there is a gap. Yeah. There is a gap here. What is this?
This.
This is malunion. Very good. So here you see there is a union which is occurring, but there is no, what is absent here? Alignment, right? So whenever the bone has to unite, if it has to unite properly, resulting in length, alignment and proper rotation, that is called LAR. You have to achieve all these three for a good alignment, right? For the good functioning of the bone. Do you think the bone will function normal here after aligning like this? No, right? So this is malunion.
No.
Yeah, this is malunion, where union occurs, but the length is not achieved. There is no proper alignment, and there is some disturbance in the rotational component also, which is not required for your level. But what is this? This is
Non-union.
non-union. Very good. Why there is non-union? There is no union only. So there is a gap which you can see. So here what you have to remember is there are two types of non-union. First one is hypertrophic non-union. The second one is atrophic non-union. So whenever I say atrophic means no. A is no in a medical terminology. So there is no callus. And whenever you see there is no callus, you will see there is a gap. So atrophic non-union is also called as gap non-union. Okay. Whereas hypertrophic, what do you mean by hypertrophic? Hyper matlab?
Increase in bonds, increase in size, hypertrophy.
Hypertrophic means there is excessive callus which is present. Callus is excessively present, right?
Yes, ma'am.
Okay, so atrophic means there is no callus. Hypertrophic is excessive callus. But here this excessive callus is not doing any work. It is not helping to unite the bone. Hence, this is called as non-union. Hypertrophic callus is present, but there is no union. Why there is no union if even though callus is present? Just think for a while. Good evening, Kalai. Pregs, you will get the PDF. Don't worry about that. So why, guys? Well, see, now what I'm talking about is, so there is a fracture and now union has to occur. That means the bone has to fuse. How the bone fuses? We know that because of the callus it fuses. But atrophic, we are sure that there is no callus, hence there is no fusion. Hence, there is no fusion. Okay. But why do you think in case of excessive callus also there is no union? What could be the reason? Yes, Kalai, what could be the reason? So here what happens is there is a lack of mechanical strength. Understood? Mechanical strength is not sufficient. Here, blood supply is not sufficient. Because of lack of blood supply, because this is lack of blood supply, there is no callus. Here, blood supply is normal, but mechanical strength is not there. So both the bones should have both things. So you have to support the bone properly, and then you have to see that there is proper blood supply. Then only the bone gets united. Okay, is that clear? Understood?
Yes, ma'am.
So how do you provide the mechanical strength? We provide it through implants. We provide it through nails and plates. So now the question will be like this. In case of the hypertrophic non-union, what is that additional requirement the bone requires? What is the treatment of the hypertrophic non-union, in other words? Yes? What would be the answer? Yes, what would be the answer? Clara, Bayan? So the treatment for the hypertrophic non-union would be Increasing the strength. So you have to either increase your plate. Yes, very good, Kale. Proper fixation. Excellent. So you have to properly fix the bone, right? And what is the treatment? Treatment for the atrophic non-union. Here the proper strength is there, but there is no blood supply. So how do you increase the blood supply? Treatment for atrophic non-union. You have to go for bone grafting. Understood? Very, very important. They will ask you. They will ask this question. So the treatment for atrophic non-union is, yes, bone grafting, and hypertrophic non-union is increasing the fixation, right? Is that clear? Then what is the treatment for malunion? What do you think would be the treatment for malunion? Very easy. Bayan, what is the treatment for malunion? Clara? Osteotomy. So you have to cut. So now what you do? You just observe. You will draw a line like this and one more line like this along the long axis of both the alignment, and then you cut and then you unite. So this is the osteotomy. Okay, the treatment for malunion is osteotomy, and the treatment of non-union depends upon whether it is an hypertrophic non-union or an atrophic non-union. Is that clear?
Yes, ma'am.
Yes.
Ma'am,
Huh.
ma'am, do you unmute Bayan?
Oh, I have. Oh, sorry. Okay. Bayan, osteotomy.
Yeah, ma'am. Thanks, ma'am.
Sorry. Okay, done. Okay, now we are done with the non-union, malunion. Now we have come with the dislocations. So what is this? This is an shoulder dislocation. So what are the types of shoulder dislocation?
Anterior, posterior.
Yes, anterior, posterior,
Posterior. Inferior.
yes, inferior. So two points for each of them. Which is the most common?
Anterior.
Yes, very good. What is the most common injury in anterior shoulder dislocation? We have discussed it.
Axillary nerve.
Yes, very good. Axillary nerve. Yes, very good. Axillary nerve. And what is the mechanism of injury? How do patients get injured in case of anterior shoulder dislocation?
Fallen outstretched.
That is for everything. They will fall outstretched only. But what happens here is they go for abduction and external rotation, right? Yes, they go for abduction and external rotation. So whenever they go for abduction, excessive abduction and external rotation, the ball which is present here will come out, right? So that is the mechanism of injury. Okay. And how do you treat it? What is the test? What are the three important tests for anterior shoulder dislocation?
Hamilton Dugas.
Very good. So first is Hamilton ruler test. Then what is Dugas?
Opposite shoulder, touching the opposite shoulder.
Excellent. Touching the opposite shoulder. So whenever the patient comes with an attitude of, abduction and external rotation, holding his hand, he is unable to internal rotate. So he will not touch the opposite shoulder. So that is your Dugas test. And finally, Calavis. Axillary circumference. Yeah, that is for axillary circumference. Okay.
Circumference.
Yes. And now what you can see? You will see a ball-like structure on the anterior aspect, right? And what is the treatment? So any dislocation is an emergency.
Kocher maneuver.
Yeah, Kocher maneuver, you will do reduction. So how you do reduction? You protraction.
Kocher.
External rotation, adduction.
And then finally, internal rotation. Okay, you remember this as T. So first you give traction, external rotation, then adduction, and then once you do all this maneuver, it will fall onto the opposite shoulder. So this is your medial rotation, or it is internal rotation. Okay, yeah, Pranavi Reddy, you can also remember that as team also. Team also is fine. M for medial rotation. So usually we remember it as TI. So that is for internal rotation. So once you do the proper maneuver, what is important here? You have to touch the opposite shoulder, and then
Opposite shoulder.
yes, and then you will put in immobilization. So how you do the immobilization? With the help of shoulder immobilizer. So you put the shoulder immobilizer for 3 weeks, at least for 3 weeks, right? And nowadays, what is the protocol is? Usually this reduction is done under anesthesia, right? So not to injure the rotator cuff and all. So you are doing it under anesthesia, okay? Yes, Hippocratic method hasn't been obsolete, Kalai, very good. So this is about anterior shoulder dislocation. Now coming to posterior, what is the most important thing? What is the sign which is called?
Adduction and internal.
Yes, adduction, internal rotation is the mechanism. Very good. And then, what is the sign which we see on the X-ray?
Light bulb sign.
Very good. Light bulb sign. And usually where we see, in which patients we see this posterior dislocation? Patients presenting with epilepsy and yes, Kalai, very good. Epilepsy and electric shock.
High voltage
Electric shock, very good. Whenever we see the patients with epilepsy and electric shock, we usually see this light bulb sign. So this light bulb sign is usually seen in posterior dislocation. Okay. And finally, what is this?
inferior dislocation.
Yeah. What is the maneuver?
Hyperabducted.
Yeah.
It is rare.
Yes. Luxatio
Saluting position.
erecta.
Luxatio erecta.
Yeah, luxatio erecta. So completely the patient will come like this, hyperabducted hand completely. Okay, so this is the inferior dislocation. Very, very rare. We usually don't see. Most common is anterior shoulder dislocation. Okay, clear?
Yes, ma'am.
Okay. Then now, so what are the complications of this anterior shoulder dislocation? If there is a recurrent dislocations or if it is an habitual dislocations, we see two important
Recurrent
things.
shoulder dislocation.
Huh?
Axillary injury.
No, I'm talking about recurrent. I mean, if there is a recurrence, like there are some 3 times of, shoulder dislocations, or if the patient is habituated that dislocations, we see 2 important complications. What are those 2 important complications? Yes, very good, Dr. Raj. The first one is Bankert's lesion. So what is this Bankert's lesion?
There will be tear of the labrum from anterior inferior glenoid rim.
Very good.
Glenoid rim will.
Yes. So here, if you remember, our shoulder is enclosed in the glenoid, right? So now this glenoid is covered by an extensive layer which is called as the labrum. So this glenoid labrum will give you excessive protection for the glenoid. So now what happens? There is a tear in this labrum, and this tear in the labrum is present on which side? Anterior and
Inferior.
yes,
glenoid rim.
anterior and inferior aspects. Very good. Anterior inferior is Bankert's lesion. Very good. And similarly, on the humerus side, what you see? Humerus side, what is the defect which is called?
Avulsion.
Hill-Sachs lesion. Very good. On Hill-Sachs lesion, it is on the posterior superior side, right? So that is Hill-Sachs.
Posterior lateral surface.
Posterior lateral. What you see here is, so what happens is, so this is the head and now it is coming out like this. So that is why glenoid, it is anterior and inferior, right? Whereas for the humerus, it is on the back side, right? So it is posterior and the lateral aspect. Okay, is that clear?
Yes, ma'am.
So for the Hill-Sachs, how you remember? H for head. Humerus is Hill-Sachs, mostly on the posterior aspect, right? Posterior lateral aspect usually, right? And then for the Bankert's, it is anterior and inferior. Okay. Yes, these two are the most important complications for recurrent or habitual dislocations. Okay. Yes, very good, Dr. Rajan Pranavi. Now we are coming to one more important thing. Very, very important. This is, so what is this? What fracture?
Supracondylar.
Yes, supracondylar fracture. Humerus, right? Yes.
Yes, ma'am.
Yes, it is a supracondylar, usually seen again in the age group of 4 to 8 years. Okay. And what is the classification of supracondylar fracture humerus? Name of the classification?
Flexion and extension to
Name.
Gatland classification.
Yeah, Gatland classification. And what is the most common type? Extension type is most common, right? And what is the most important thing? The 3-point bony relationship is intact. Yes. So in elbow, how we talk, usually we talk as a 3-point bony relationship, right? So what is the 3-point bony relationship between your medial epicondyle, lateral epicondyle, and your olecranon, right? Okay, is that clear?
Yes, ma'am.
Yeah. So now, whenever there is a 3-point bony relationship maintained and then there is a fracture, we usually call that as supracondylar. In which fracture this 3-point bony relationship is disturbed?
Lateral condylar fracture.
Yes.
Medial condylar fracture. Or leg crano. Elbow dislocation.
Yes, perfect. Whenever there is a intercondylar fracture, whenever the fracture is extending into the joint, you will see that the 3-point bony relationship is disturbed. Very good, Raj. And what is the most common complication of the supracondylar fracture? Yes, involvement of brachial artery, BIC, and then nerve injury. So what is the most common nerve it is damaged? Huh?
Anterior introsus.
Yes, remember as AMRU. So first is anterior introsus nerve, followed by median nerve, followed by radial nerve.
Radial nerve and ulnar nerve.
Very good. So whenever there is a brachial artery involvement, it can also lead to Wiedemann's ischemic contracture. And this brachial artery, whenever it is injured, so always you have to check for the radial pulse when you see a patient with the supracondylar fracture, right? And what is one of the most important thing? So because this is not a joint, so it is just above the joint, it will result in, what is this condition? Is this a malunion or a non-union?
Malunion.
Yes, very good. This is a malunion, right? And what is this deformity which is called?
Gunstock deformity.
Yes, Gunstock deformity or cubitus.
Paris.
Yes,
Paris.
very good. It is a Gunstock deformity or cubitus varus deformity. So it's a malunion mostly which occurs in your supracondylar fracture, which will result in cubitus varus. It is also called as Gunstock deformity. So what is the treatment for malunion? Told you already?
Osteotomy.
Osteotomy. So here the name given to this is the French osteotomy. Okay. It is called the French osteotomy. Name, just remember the name. Okay, that will be enough for this. Okay, and then so here I have told you varus is mainly seen in supracondylar fracture. Then where is valgus seen? Cubitus valgus. Which fracture? Yes, lateral condylar fracture. So lateral condylar fracture will usually result in cubitus valgus. And what is one of the most common complication of this valgus? Late complication, which is called as Late complication. Yes, Kalai? Tardy?
Ulnar nerve
Yes,
palsy.
tardy ulnar nerve palsy. What do you mean by tardy? Slow. Tardy का मतलब है slow. So what is cubitus valgus? So valgus is like this, no? So there will be lateral side which is not forming and the medial side will increase, right? So medial side there will be growth. Lateral side the growth is restricted, right? So because of that there will be stretch of the ulnar nerve and this is seen as a late complication. Hence this is called as tardy ulnar nerve palsy. Okay? So whenever the patient of, you know, some 10 years old presents with claw hand, so you have to examine for this cubitus valgus deformity. Is that clear?
Yes, ma'am.
Yes, done. Okay, now what is this? Important forearm fractures. Two important forearm fractures you have to remember. These are nothing but these are called as fracture dislocations. क्या है? First one is what? A and B.
Montage.
Yes, very good. The first one is Montigia. The second one is Gellesi. Very good. So what is Montigia? Ulnar. What is Gellesi?
Proximal or middle ulnar fracture.
Yes. So whenever there is So Montigia is nothing but your proximal ulnar, ulnar fracture is there associated with. So this is ulnar and associated with radial head dislocation, right? So what is radial head dislocation? It is proximal radio-ulnar joint dislocation, right? So whenever there is ulnar plus proximal radio-ulnar joint involvement, that is the example of Montigia. And whenever there is radius fracture, so this is radius fracture and involvement of distal radio-ulnar joint is your Gellesi. How do you remember? Remember Murg. M-U-R-G. Okay?
Yes, ma'am.
Medial Montigia is for ulnar. So once you remember it as ulnar, always remember the radial head dislocation. And radius is for Gellesi. Okay, radial fracture is Gellesi. Okay, these are two called the fracture dislocation. So why am I specifically mentioning about this? These are fractures of necessity. So they require absolute what? Absolute reduction. Absolute reduction. That means you have to go for surgery. No role of conservative treatment here. Okay. There is no role for this. There is no role for conservative treatment. You have to treat them with surgery. Okay. Go sleep. Okay. Now what is this? The next one.
Colles fracture.
Yes, very good. This is your Colles fracture, right? And what is a Colles fracture?
Distal end of radius.
Okay.
Corticocalcaneal junction.
Okay. First one, what is the first word you have to tell me? It is an extra-articular fracture. It is an
extra-articular fracture.
Extra-articular fracture. Why is that important for us? Because there are other intra-articular fractures. So what is the example of intra-articular fractures? Barton's fracture. So Barton's fracture is your intra-articular. This is your extra-articular fracture and usually seen in which scenario of patients?
Postmenopausal woman.
Very good. Postmenopausal woman.
Elderly.
Elderly, postmenopausal, and it is an indication of osteoporosis. It is an indication of osteoporosis. So how do you treat it? And what is the most important thing about this Colles fracture? It is an extra-articular fracture with the displacement. What is the displacement? So whenever there is a fracture, the fracture fragments tend to displace. So whenever it is an extra-articular fracture seen in metaphysis with a dorsal displacement, then only you comment this as your Colles fracture. Okay. What are the other displacements we see in Colles fracture?
Lateral.
Supination, impaction, dorsal tilt, dorsal displacement.
Lateral.
Yes, very good. Lateral tilt and lateral displacement. So these are all the
Displacement.
these are all the things. Yes, these are all the things which we see in the Colles fracture. Right? What is the treatment for Colles fracture?
Below cast.
Yes,
Below elbow
Colles.
cast.
Okay, Colles cast. So how do you put the Colles cast? What is the position of the casting?
Below elbow cast.
Yeah.
Also handshaking cast.
Hey, not handshake.
Flexion of the
Handshake.
pronation, ulnar deviation,
Yes,
palmar.
yes. Palmar
Flexion.
flexion, ulnar deviation. So you go for palmar flexion and ulnar deviation. Charting. Palmar flexion and ulnar deviation. So now you put the palmar flexion, then you do ulnar deviation. So the bone gets set, and now you do the casing, right? This is called hand shaking, not glass holding. The Raj, glass holding is for your scaphoid fracture. We'll just come to this. This is glass holding position. That is for scaphoid. This is almost like the hand shaking. Okay. Palmar flexion and ulnar deviation. This you have to remember. Okay. Then what is this?
Inner fork
Inner fork
Inner
deformity.
fork deformity. And what is this? Malunion or non-union?
malunion.
Non-union.
Huh?
Malunion.
I can hear malunion, non-union both. Bayan, it is not non-union, it is a malunion. The complication of Colles fracture is malunion. Okay?
Okay, ma'am.
Yes, malunion, because it is again extra-articular. Whenever something is intra-articular, you can expect non-union. So here, the examples of malunion. So first, what are the examples of malunion we have seen? So first is Colles, then supracondylar fracture humerus, then
Neck of
neck of,
femur.
that is non-union, that is intra-articular. Intertrochanteric fracture, IT fracture is an example of malunion. Okay? So these are the examples of malunion. See, if when something is 3, you have to be very careful. 4th one will be your option. So what are the areas where you expect malunion? Yes, repeat. Colles,
Colles fracture.
supracondylar,
Subcondylar fracture, intertrochanteric fracture.
IT fracture.
Intertrochanteric fracture.
Okay. Where you expect non-union? Areas of non-union?
Neck of the femur.
Yes, neck of the femur.
Neck of the femur.
Then, yes, Kalai, Raj, answer. Yes, guys, neck of the humor. Scaphoid. Next,
Lateral condylar.
talus. Yes, lateral condylar humerus. Okay, these are the important areas of malunion and non-union. You have to remember. Yes, Dr. Raj, correct. Both scaphoid, talus, these. What is the most important thing about all these three? Aberrant blood supply, right? So the blood supply is little different for all these three. The scaphoid, the talus, and the neck of the femur. Hence, they result in non-union. Okay? Okay, now. So this is a dinner fork deformity, which is usually seen in Colles fracture. That is malunion. So what is this? This is garden spade deformity. Where you see this garden spade deformity? What is opposite of Colles fracture?
Smith fracture.
Yes, Smith fracture. Very good. What is Smith fracture? So whenever the fracture occurs extraarticular and goes into ventral displacement, that is called as your Smith fracture, exactly opposite of Colles fracture. Hello,
Reverse Colles fracture.
Reverse of Colles fracture, that is Smith's fracture, ventral displacement, and the here also it is malunion only, but that will result in what? Your garden spade deformity.
Garden spade.
Okay, next, what is this? Very important.
Scaphoid.
Yes, scaphoid fracture. And what is the area?
Snuff box.
Anatomical.
Snuff box.
Yes, anatomical snuff box. So you have to, what you have to do? You have to palpate. And if you see a tenderness in the anatomical snuff box, then you have to suspect for your scaphoid fracture. And usually scaphoid fracture, usually we miss the scaphoid fracture, right? We tend to miss the fracture. And that is why what are the views which we take out? So one
Oblique.
is, very good. You go for the oblique view. Very, very good. So you go for oblique view where you can see the scaphoid fracture. So RDC Singh, ma'am, for FMG, is this sufficient? See, almost we are covering entire syllabus. If you see, it is not only IBQ. So we are also dealing with the entire syllabus. I think this will be sufficient, provided you read everything from this, not leaving anything, okay? So this is the oblique view, and what is the main investigation of choice to identify your fracture? So first X-ray, and there is a high chance of the scaphoid going into what? What complication?
Non-union.
So how do you identify non-union? What is the investigation of choice? Yes, MRI. You have to go for MRI. So this is the MRI what I was talking about, and if you see, you can see that there is a difference with the other carpal bones. You can see something which is abnormal here. So this is the MRI. Yes, this is the MRI, and this is the non-union, right? And what is the treatment for scaphoid fracture?
Glass holding cast.
Yes, glass
If it's
holding.
an undisplayed fracture.
Yes, if it is undisplaced, it is a glass holding cast. Okay.
And
So now
for
how
the
do you
displays,
identify whether this is how do you identify this is Colles cast and this is glass holding cast?
Thumb.
Very good. So thumb is enclosed in scaphoid. Okay. In the exam, we tend to get confused, right? So sometimes we might mistakenly identify Colles as glass holding cast. So if you see, the thumb is free in case of Colles cast. So you will also ask the patient to do the movements of the thumb. Whereas in scaphoid cast, what we do, we enclose the thumb. Okay. That is the major difference which you have to remember. Good. Then what is this? Two important fractures which can confuse you. So first one is your, what is the name of the first one? Thumb. I mean your,
Bennett.
yes, Bennett's and Rolando.
Rolando.
Rolando. Bennett's and Rolando. So Bennett's, remember, Bennett is bi. So there are two fragments here. So if you see, it is two fragments. Rolando is 3. So this is Y or T-shaped.
Complete fracture.
Okay. So Bennett's is bi. But why you have to very much concentrate on Bennett's? Because there is a pull of this tendon. So if you see, your abductor pollicis longus tendon, APL tendon, is attached to this longer fragment. Okay. This longer fragment, it is getting attached and it tries to pull the fragment downward. So that is why there is a problem in healing of this Bennett's fracture. So that is why this requires absolute reduction again. Okay. Both are intra-articular. If you see, don't get confused. One is extra or intra. Both are intra-articular. But Bennett's is bi. There are two fragments, and the longer fragment, you see, it is attached to a tendon. And this tendon keeps pulling the fragment, not allowing it to heal. So that is why we do absolute reduction with the help of K wires. Okay. That means whenever I say absolute, that means you have to go for surgery. Okay. Yeah, Cristiano Rolando, you can remember. So this is Y or T shape. This is a comminuted fracture. Okay, what do you mean by comminuted? When the fracture fragments are more than 3. Clear? That is comminuted. So
Yes, ma'am.
Rolando is a comminuted fracture. Bennett's is a bifragment fracture. There are 2 fragments in it. And what is this? This also starts with B. And you see it is in the 5th metacarpal neck.
Boxer structure.
Very good. It is
Boxer
boxer.
structure.
Very good. Boxer's fracture. How do you treat the boxer's fracture? You can treat it conservatively if there is,
Bowler.
or you can go for pins, K-wires. Okay. 5th metacarpal is boxers. First thumb is Bennett's. Don't get confused. Okay.
Bennett.
Yes, ma'am.
This is metacarpophalangeal. Okay. And this is the neck of the 5th metacarpal. Okay. Then what is this? What is this?
Gamekeeper's.
Ah, very good. Gamekeeper's
Gamekeeper's
thumb. Yes. And this is called the Steiner's lesion. Yeah, Steiner's lesion. Yes, Kala. This is a gamekeeper's thumb. This is called the Steiner's lesion. Okay. And then now, this has been asked in the exam. It is asked in the NEET PG. So what is this? So whenever there is a pelvis fracture, what is the first step you do? What is the first step you do in case of a pelvis fracture? So you're suspecting a patient to have the pelvis fracture. And what is the importance of pelvis fracture? Patient might bleed internally, right? So there are various internal organs which are present. So there is a high chance of patient bleeding. So what is this we are tying to the patient? What is this called? Pelvic binder. Okay. So this is the first step. What we do is we put the pelvic binder. So what we do, it compresses the pelvis. So whatever bleeding happens, we can stop to some extent. At which level you put this pelvic binder? So you can use a bed sheet if it is not available, or you get a pelvic binders available at the stores. So at which level, which level we put the pelvic binders to compress the pelvis? At the level of greater trochanter. Okay, both the GTs has to be combined. So you will identify the GT, and at the level of the GT, you will bind the pelvis tightly, either with a bed sheet or with the pelvic binder. This is to compensate for the loss of the blood. Then patient, you have to check for the shock. Okay. So this is one of the important questions. Okay. Next, once talking about the pelvis, what is the most important thing? Important topic.
Posterior dislocation.
Yes, very, very, very important. Posterior dislocation of the hip. So here, if you see, what is the first thing? What is the attitude of the limb in posterior dislocation? Yes, Kalai?
Adduction.
Flexion?
Flexion, adduction, internal rotation.
Yes, very good. Father. So flexion, adduction, and internal rotation. And you see this X-ray is example of your posterior dislocation, where head appears to be small. And most common complication in this thing is, which nerve gets induced? Sciatic nerve. Yes. Posteriorly, what nerve is present? Posteriorly, there is sciatic nerve. So sciatic nerve will result in which complication? Foot drop. Foot drop, yes. So sciatic nerve has 2 components, right? So one is your tibial nerve, then is the common peroneal nerve. So here also the common peroneal nerve will get injured, and now there will be a foot drop. So you have to always examine the patient for posterior dislocation. You have to examine for the foot drop. Okay. And here the most important thing they'll ask you is about the attitude of the limb, that is flexion, adduction, and internal rotation. And then what is this? What you can see here? Yes. So there is a fracture. Neck of femur, right?
Yes, ma'am. Yes.
Yes, you can see that there is a sentence line is broken like this.
Intracapsular fracture.
Yes, IC fracture. So this is your intracapsular IC fracture. And here the second one is
Extracapsular. neck of femur.
extracapsular or your intertrochanteric between GT and the LT. Right? So this is your IC fracture. This is your IT fracture. So what is the complication which I have told you in IC? It will result in
Malunion.
A.
Non-union.
Non-union. It is
IT is malunion.
IT is malunion. IC is non-union. Why IC is non-union? Because it is inside the capsule and they will have synovial inhibitors which will inhibit the union, right? So malunion is extracapsular, right? So here union occurs, but alignment is at a problem. So this is malunion. So what is the treatment for IC fracture? That is important. How do you treat this? Treatment for non-union 𝐒𝐿 or fracture neck of femur? Hemi?
Arthroplasty.
Yes, hemiarthroplasty. What do you mean by hemiarthroplasty? So you are replacing the head of the femur, right? You replace this by?
Neck of the femur.
Yes, prosthesis. What are the prostheses which we use? Austin Moore side?
Bipolar, Austin Moore, Thompson.
Thompson, very good. So now hemi means half. Plasty means replacement. Understand? Ortho is joint. So you're going for half joint replacement. So you're replacing the head of femur. Understand? So you will replace this head of femur with the prosthesis.
Yes, ma'am.
And what is the treatment for IT fracture? Proximal femoral nailing. That is PFN. Okay, very important. This has been asked in the INSCT. 3 questions have come. So the first question was, what is the treatment of IC? Second question was, what is the treatment of IT? Okay, in the same exam they have asked. So first, what is the treatment of IC? Hemiarthro?
Hemiarthroplasty.
Very good. Treatment for IT?
Proximal femoral nailing.
Proximal femoral nailing. Very good. Very good, Raj. So now next one, what is this? This is femur fracture, right? You can see there is a fracture femur. So now what is the treatment for fractured femur? Yeah, shaft of femur. So what is the treatment for shaft of femur? This is also nailing, but this nailing is intramedullary interlocking nail. Okay, that was proximal femoral nail. This is intramedullary interlocking nails. So what do you mean by intramedullary? So we are putting the nail inside the medulla. We are putting the nail inside the medulla and we are locking it above and below. Got it?
Yes, ma'am.
So here what I am doing, proximal femoral nail, I will put a screw into the head like this and then I will put a nail like this. So this is head, cephalomedullary nail. Understood? Cephalo ka matlab hai, it is in the head. Okay? This is intramedullary. So here there is nothing in the head, no screw in the head. So only intramedullary interlocking nail. Okay, yes, Dr. Raj, you can call this as close reduction internal fixation because usually this shaft we will try reducing it close reduction. Okay, And this is also, you can call this as close reduction internal fixation. Okay. And if such a fracture, if it occurs in the patient of less than 2 years, so what the traction you give?
Gallows.
Yeah, gallows
Polish
traction.
harness. Gallows traction.
Pavlik is for DDH. So
Less
this
than
is,
6 months.
yes, less than 2 years, you go for gallows traction. Okay. Less than 6 months or infant, this is what
Polish
is called
harness.
hip spica.
Hip spica.
Yeah, this is hip spica. So whenever there is an involvement of your limb and the abdomen together, this is called as hip spica. And if the patient is weight bearing for if more than 5 years, then what is the treatment for fracture shaft of femur? What are these nails?
Flexible nails.
Yeah, flexible nails. The name
Or
given
endless
is
nails.
tense nails. Endless nails. Endless nails are not flexible. Tense are flexible. These are titanium elastic nailing system. So they also tend to increase, right? Whenever the bone is growing, they accommodate the growth of the bone. So if the patient is more than 5 years, you go for tense nailing. 6 months to 1 year, you can go for your hip spica. If the patient is an infant, you can go for gallows traction. Okay. Sorry, this is less than 1 year. Okay. Got it?
Yes, ma'am.
So that is about the fracture shaft of femur. If the patient is an adult, you go for intramedullary interlocking nail. Okay. Then what is this? What is this cast? This is called the cylindrical cast. So if you see, this is it is only up to the malleoli, right? So this is in extension. So this is extension cylindrical cast. Where we use this cast in case of your, what is this fracture?
Patella.
Yeah, patella fracture.
Patellar fracture.
Yes. What is this view called? This is called,
Skyline view.
yeah, skyline view. Called the skyline view. Okay. And now recently in the NEET PG, they have asked about the biparitate patella. So usually this will resemble as the fracture patella, but what we see is, it is usually on the, the fracture, if it is a fracture, you will see the lines are irregular like this, right? So here the lines are not so irregular. And usually whenever it is a biparitate patella, what you have to do, the next line of management will be, you have to go for the opposite X-ray. Right? Opposite knee X-ray. That means usually it is bilateral in condition. Okay? And usually the fragment will be upper superior fragment like this. So the upper part, upper superior fragment will not fuse, and this will see as biparitate patella. Okay? Raj, not biparitate fracture of patella. It is biparitate patella. That means there are two patella like. Okay? Fracture of patella is this. It is usually in the center and the surfaces are irregular. Okay? And for conservative treatment of patella, what we use? This cast. So what is the name of this cast? Yes?
Cylindrical.
Very good. Cylindrical cast. Okay? Now let's go to the sports medicine. This is again very, very important. So there are various tests which you have to remember. I will tell you only the name of the test. Okay, the first one is anterior drawers test. So this is for testing your ACL, anterior cruciate ligament. Okay.
Yes, ma'am.
Okay, feeling sleepy?
No.
So this is for anterior cruciate ligament. So you are going to just, what you are going to do? You are going to put the limb in flexion, and this limb in the flexion will limb in the flexion, and you will try to pull the tibia forward. So this is called your anterior drawers test. What is the second one? McMurray's test. McMurray's test is for your meniscus. Yeah, both medial meniscus and lateral meniscus. And what is this? This is called the Thessali's test. This is also for your meniscus, Thessali's test. Okay, you're going to stand, you're going to help the patient on standing, and the patient will rotate. Okay, medial rotation, lateral rotation on standing. This is called your Thessali's test. And what is this? This is your Apley's grinding test. So this Apley's grinding test is in the prone position, right? We are doing this is in the prone position. Okay. So there are 3 tests for meniscus. One is your McMurray's test, Thessali's test, Apley's grinding test. And for anterior drawers test, it is ACL. For posterior drawers test, it is PCL. Okay.
Yes.
Okay. Anterior drawers, ACL. Posterior drawers, PCL. Latchman's, ACL. Pivot shift, ACL. And the most sensitive is for ACL, most sensitive test is, yes, Latchman's. Most specific test is pivot shift, and this is usually done under anesthesia. Okay. No need the maneuver for pivot shift test, not required. Just remember, for ACL, the most specific test which is done under anesthesia is pivot shift. Okay. And Latchman's, what you have to remember, this is done at 15 degrees of flexion. How it is different from anterior drawers? Here, this is done in 90 degrees of flexion. Okay. Clear ACL test? 3 tests are there for ACL. Anterior drawers, Latchman's, pivot shift. Okay, guys? Confusing? Is it confusing? Shall I repeat?
No, ma'am. No.
So ACL, remember, 90 degrees of flexion, and you're trying to anteriorly pull the tibia. Posterior drawers, you're trying to push the tibia, right? So whenever the patient is in acute condition, like there is, a lot of pain for him where he can't do 90 degrees of flexion, we go for 15 degrees of flexion. That is your Latchman's. And to confirm on the before going into scopy, what we do is pivot shift test. Okay. Then McMurray's, what did I tell? McMurray's, Thessali, and Apley's grinding is for your meniscus. Very good. Right? And then we have your varus stress test and valgus stress test. So this is for your
Collateral.
very good. The collateral ligament. Very good. Excellent. So collateral ligament and collateral ligament, there are 2 types of collaterals, right? Medial collateral ligament, lateral collateral ligament. So varus stress test is?
Lateral.
Yes, LCL. Valgus is? MCL. That's it.
Medial.
Yes, medial collateral ligament, you give valgus stress test. So whenever you're doing valgus, that means you're stretching the medial side, right? So there will be opening of the medial compartment if there is a MCL tear. Okay. Yes, this is valgus stress and varus stress. Okay. Then what is this? This is Thomas test. Checking for the fixed flexion deformity of the hip. Okay. That is Thomas splint. This is Thomas test. Okay. Thompson test is for? This is Thompson test. Thompson test is for your tendo-Achilles. So whenever there is a tendo-Achilles tear, what you do, you squish. You compress. What you do is you press the gastrocnemius and soleus. That is what forms the tendoachilles, right? So whenever there is a tendon intact, it will call plantar flexion. If the tendon is not there, it will result in no plantar flexion. So this is your Thompson test. Okay, this is your FFD is for your Thomas test. Okay, clear guys? Confusing?
Yes, ma'am.
Clear. Yes, Bayan? Is it okay? Should I repeat?
Yes.
Yeah, ma'am.
Clear now? Okay.
Yes, ma'am.
Okay. Now these are the lower limbs test. What I was talking about. Now come to the rotator cuff tears. So what are the rotator cuff tests we have? So first one is your supraspinatus tear. So what is the test for supraspinatus? What is this? Empty can test, right? So supraspinatus is mainly for your abduction, right? It is for initial abduction. So for testing your initial abduction, you will put the empty can like this, and then you try to test the abduction. So that is your supraspinatus. And then you have your subscapularis test. So subscapularis is mainly for which one? What is the action of subscapularis? Action of subscapularis. Internal rotation, right? Okay, so we have two important tests. One is lift off test and belly press test. Okay. Okay, so internal rotation like this. So teres minor we are for external rotation, I told you. So this is subscapularis for internal rotation. So you are going to press the belly. So this is belly press test and lift off. It is also called as your Gerber's lift off test. So now we are going to put the hand at the back as shown in this figure. So this is your lift off, and then you are asked the patient to lift the hand up off the back like this. Okay, lift off test. Okay, is that clear?
Yes, ma'am.
Yeah, this is belly press test and this is your lift off test, and this is your Thompson. Thompson is for tendoachilles. Remember, Sun is for tendoachilles, right? Thomas is for hip. And what is this test? This is straight leg raising test. Okay, you have to just raise your leg straight without flexing of the knee. So whenever you're able to do, it is normal. If you have a pain at less than 60 degrees of elevation, then this is an indication of your prolapse intervertebral disc. Okay, this is for, yeah, very good, Raj. It is PIVD, SLRT. Okay, these are the various tests which you have to remember. So this is very, very important. So there are various tests. I have put everything in one slide. Just before going to the exam or 2 days before the exam, just open this slide and revise. Okay. Anything it is confusing which you want me to repeat? No, right?
No, ma'am.
Okay. So now see, just don't get tensed, because we have one more class maybe on 25th of April again. There I'm going to take a detailed discussion of everything. So now, because it is, you know, lack of time also, I'm just hurrying up, just telling you the names. Okay. There I will tell you why Thomas test is done. Okay. What is the importance of the Thomas test?
Okay,
for now, just remember it is for your flexed flexion deformity of hip. Okay. So now, what is the investigation of choice for your ACL or MCL tears? It is MRI, right? You have to go for MRI. So this is the presence of your ACL. So this is the ACL. This is ACL. So whenever this ACL is absent, that means you will have the ACL tear. Okay. So for that I have bought this, and this is your PCL. Okay. These are the two things which you see on the MRI whenever you want to diagnose the tears. Okay. And what is this fracture? Lateral condylar of which bone? Tibia. What is this fracture called? It is called, the name given is bumper's fracture. Okay. So usually the bumper, we tend to, hit on the lateral side, right? On the medial side, it is usually protected by the other leg. On lateral side, usually they come and dash, right? So this is called the bumper's fracture, tibia. Okay, lateral condylar tibia. Now list angles. So these are all the angles. So what is this angle called on the upper limb? This is called the carrying angle. Yeah, this carrying angle usually decides whether the limb is in varus, that is your elbow is in valgus. Okay. So usually what we have varus or valgus normally. Normally our elbow is in valgus. Just like this, right? So normally it is in valgus. Okay. This is carrying angle. What is this? What is this angle? Yeah, 𝐒𝐿𝐻's angle. Where do you see this?
CT.
Yes, CTV. What is 𝐒𝐿𝐻's angle? It is nothing but your parallelism of talus and calcaneum. So in CTV, what happens? There is a problem in the foot bones, right? So these bones are arranged in such a way, usually it is at an angle. So 10 to 15 degrees of angle is there, tibiocalcaneal angle. So this angle now becomes 0 degrees. That means they both become parallel. So this is called the 𝐼TE's angle. So this has been asked in the exam, very, very important. 𝐼TE's angle is seen in CTV. Very good. And what are these angles? These are the angles of the calcaneum, right? So there are two important angles. So first one is your Bowler's angle. The second one is Gisane, crucial angle of Gisane. So which increases, which one decreases? In calcaneum fractures. Gisane gains. That means Gisane increases. Remember, Gisane gains. In case of calcaneum fractures, if Bowler angle decreased, Gisane angle will increase. Okay? Clear? So how do you draw the Bowler's angle? So Bowler's angle, how I draw? There is a tip. This is the posterior side, no? Highest side on the posterior aspect. So you draw a line like this. And the second one, how do you draw is you touch both this anterior and the posterior facets like this. So this angle is called the Bowler's angle. Okay. And these are the struts, right? So Gisane is very easy. Just these are the facets. This is anterior, this is posterior. So just you draw lines along this, lines like this. So this is your Gisane angles. Okay. So that is Bowler's and Gisane's. Okay. Next, these are some of the fractures. Shall we continue the next class? Or should I continue now? Continue? Yes. We have like some more 5 slides. Should I continue? Okay, that's fine for me. I can continue, no problem. Rishabh is asking for next class. Okay, so we'll just complete of this. Okay, now these are some of the important fractures. So what is this fracture? This is? Yeah, this is a talus fracture, also called as Aviatus.
Aviation.
Yeah, aviatus fracture. So talus fracture is also called as your aviatus fracture. And what is this sign? So what is the most common complication of talus fracture? We have discussed already. It results in non-union. Very good. What is this sign? This is called as the Hawkins sign, right? So what is an Hawkins sign? What is the Hawkins sign? So Hawkins sign is, so what happens is whenever there is lucency in the subchondral level, that means the bone is viable. The bone is viable. So subchondral level, if there is lucency, the bone is viable. If there is sclerosis, I have told you the sclerosis is a good sign or bad sign. Sclerosis is white color, density. So is that a good sign or bad sign?
Bad.
Very good. Bad. Why bad? No resorption. No resorption means no blood supply. Understood? So if there is lucency, that means there is blood supply. That means the bone is viable. So Hawkins sign is whenever there is lucency, you see where the bone is viable. It is a good sign. Understood? Whenever there is sclerosis, it is a bad sign. There is no resorption and their bone is dead. That means it is going into non-union. Is that clear? Yes, clear?
Yes, sir.
Yes, good. So that is about your Hawkins sign. Then what is this? Which fracture is this? What is this? Fifth metatarsal base. What is this called?
Jones fracture.
Yes, it is called the Jones fracture. So fifth metatarsal base, there is a fracture. You can see this is the fracture. Fifth metatarsal base, this is the fracture. So there is a fracture. This is called as the Jones fracture. Clear? And these are some of the pediatric fracture. What is this fracture? You can see there is a buckling here. So this is called as the torus fracture. Okay? What is this fracture? This is your green stick fracture. Yeah. What happens in the green stick? There is a bending, right? There is a fracture at one end and there is a bend on the opposite side. So that is your green stick fracture. What is torus fracture? Torus is something like this. So this buckling of the cortex is called the torus fracture. Okay. And what is this? This is a simple tibia fracture which is called as the toddler fracture. Usually seen in tibia. Okay. Is that clear? Yes. Dr. Raj, you have been asking about the pseudo-Jones, no? Pseudo-Jones is nothing but there is an avulsion. This is the pseudo-Jones is an avulsion fracture where the tendon gets attached there. So there is an avulsion fracture which is called as pseudo-Jones. So Jones is complete fracture here, right? And pseudo-Jones is this avulsion fracture where the tendon is attached. Okay? This is for Raj who has asked on the YouTube. Okay? Then what is this fracture? This isolated ulnar fracture. What is this called? This is called as nightstick fracture or lathi. So whenever somebody is trying to beat you, you put your hand opposite, right? To just defense mechanism. So there will be an isolated ulnar fracture. With the lathi stick, usually policemen will do that, right? So this is called the nightstick fracture. Only isolated ulnar fracture will be there. Okay? Clear, guys? Yeah, it is a sort of a defense injury. And now this is Salter-Harris classification. So this is also very, very important. I'll tell you in a very easy way. Just 2 minutes. So it is Salter-Harris. And what is this type of fracture? It is a growth plate injury. Okay. So whenever there is an involvement of growth plate, you have to take the help of this Salter-Harris classification. So here the mnemonic is easy. You have to write the word Salter, and there are 5 types to it, right? Type 1, type 2, type 3, type 4, and type 5. So first one is straight. S for straight. That means there is a fracture which is occurring through the which part of the growth plate? Zone of, which one is the weakest area in the growth plate? Zone of hypertrophy, right? Yeah, zone of hypertrophy is the weakest area. So there will be a fracture which is occurring right across the zone of hypertrophy, which is straight. That means it does not involve metaphysis or the epiphysis. Through the physis, right? And when it comes to type 2, it is above, A for above. That means it is involving the metaphysis as well. Okay. And what is type 3? It is lower, L for lower. That means it is involving epiphysis. So physis lower, it is epiphysis, above it is metaphysis. And this is through, T for through. That means it involves all the 3. It involves metaphysis, physis, and epiphysis. So the fracture process from the metaphysis and epiphysis. Okay. And finally, ER is crush injury. Okay. That means completely the growth plate is damaged. Easy? So this is the theory. Now I'll show you the practical. So this is the normal physis. This is normal physis. And if the fracture is just going through the physis like this, zone of hypertrophy, this is called type 1. So the example of type 1 is your skiffy. If you remember skiffy, right? Okay. There is a fracture like this, and whenever this fracture is going through the growth plate and going above the physis, this is your example would be your supracondylar humerus, where it involves the metaphysis, right? And the third one is your epiphysis, that is lower. So here the example would be your lateral condylar fracture. Okay, it is going towards intercondylar. And here if you see, it is through. That means it is starting from the metaphysis and epiphysis. This is usually seen in tibial fractures, lower end of tibial fracture. And this is crush injury, ER. Yeah. Okay, Raj has reminded me that this supracondylar humerus, there is a fragment here, right? So this is called the Thurston-Holland fragment. So you can, this is also a potential MCQ. So there is a Thurston-Holland fragment which is seen in type 2. Okay, that the metaphyseal fragment is called the Thurston-Holland fragment. Is that clear? Salter-Harris classification? Yes?
Yes, ma'am.
Okay, good. And now we are dealing with the pediatrics. So the first important thing is your CTEV, right? CTEV, very, very important. So what happens in CTEV? There is this is a deformity, congenital talipes equinovarus, right? Okay. And what is this? Usually we treat it with the serial casing, right? So when do you start casing? As early. So usually in the first week of birth, right? So this is serial casing which we do. We do the above knee casing, right? And what is this? What is this splint?
Dennis Brown.
Yeah, this is called the Dennis Brown splint. Very good. So this is mainly for the maintenance.
Up
So
to 5 years.
yeah, up to not up to 5
5
years. No. It is up to 1 year only. So now the patient starts walking, right? 1 year. Then you go for CTV shoes. Okay. This is 6 months to 1 year. You go for Dennis Brown splint. So initially you go for 24 hours. Then you go for 12 hours. Okay. So this is the Dennis Brown splint and this is your CTV shoes. When the patient starts walking, immediately you have to go for CTV shoes. So what is the importance of CTV shoes? How they are different from the normal? You have to remember 3 important things. So first is the straight inner border, right? The inner border will be usually straight and there will be outer rise. So this is the outer rise and there will be no heel. Understood? So usually what happens is varus is something which is going inside like this, right? So you don't want the varus to happen. Hence you will put the straight inner border. And again varus is something like this. So you don't want to go again into like this position. So outer raise. So lateral side you will give a raise. And completely it doesn't go to it. You doesn't want it to land up in plantar flexion again. So that is why there is no heel. Understood? So that is the importance of your CTV shoes. Okay. And this Dennis Brown splint, you put this baby in abduction position. So there is a bar which puts in abduction position and slightly external rotation like this. So that is the importance of your Dennis Brown splint. Yeah, Ponseti method up to 2 weeks. No, that is up to 6 weeks. So usually every week we change the casing, right? Every week we change and it will take up to 6 weeks for correction. So what is the method of correction? So we use the Ponseti method of correction. What is the order of correction? This is very, very important. First you correct the cavus, then you correct the adduction, then you correct the varus, then you correct the equinus. Very good. So last to be corrected is equinus. Okay, so that is about CTV. Then coming to DDH. So this is your DDH. So developmental dysplasia of hip. There are 2 important screening tests. So first one is your Barlow's. Second one is Otterlani. Yes. So what is Barlow's and what is Otterlani? Yes. For Barlow's, you are getting the hip outside. So for getting the hip outside, what will you do? Adduction and internal rotation, right? Your father. For Otterlani, you do abduction and external rotation. So you're trying to put it inside. Okay, guys? Just remember your posterior dislocation of hip. Father is Barlow's. You're getting it outside. So you do adduction and internal rotation. So when you do abduction and external rotation, they go inside. Okay. So these are the 2 important screening tests. Okay. Now this is your Pavlik harness. This is your Pavlik harness. So what is the treatment for DDH? So this is the table which we follow. If the patient is less than 6 months, you go for Pavlik harness, right? So this is the Pavlik harness, okay? And then if the patient is more than 6 months, you can go for close reduction. So you will try close reduction and then you put in hip spica. But when the patient reaches 18 months, that is 1.5 years, okay, then you have to go for open reduction because there will be contractures of all the capsules and ligaments and it will not allow for close reduction. So you have to go for open reduction. If the baby is more than 3 years, that means the baby has already started walking. So here what you do, you go for osteotomies. And finally, if the patient enters into teenage, you go for total hip replacement. Okay. So DDH, what you have to remember is this, that is 2 important screening signs. This X-ray, we will deal again later. So usually they will not ask X-ray for FMG students, usually. Okay. But what they usually tend to ask is, what is the treatment for this? The treatment is Pavlik harness. Okay, and this is the complete guideline for the treatment depending upon the age of the patient. Is that clear? Any
Yes,
doubts?
sir.
Bayan, any doubts?
No.
No.
Okay. So what is this? Which condition is this? This is Perthes disease, right? So this is Perthes disease. What is Perthes? Perthes is nothing but avascular necrosis of your
Vascular necrosis of the
femoral head. Which age group usually we see? 4 to 8 years. This is because again there is a blood supply which is not very good in case of this age group, 4 to 8 years age group. There is some disturbance in the blood supply, hence the this femoral head will land up in avascular necrosis. Okay, so what is the treatment for Perthes disease? You have to just remember the treatment is containment surgery. That means you have to see that the head is put inside the acetabulum. So this is achieved by your varus osteotomy. So this varus osteotomy we'll do and we'll put the head inside. So once it is staying inside, it is a self-resolving disease. This is avian. So but this is a self-resolving. You have to just see that the head is sitting inside. If it is not put up inside properly, it will develop into coxa magna. That means big head, where again you can't put it inside. Okay, so just remember Perthes is there is a femoral neck avascular necrosis of the femoral head, usually seen in 4 to 8 years, and the treatment is your containment surgeries. Okay, and then what is this? This we have already discussed. This is skiffy, right? So you can see there is a slipped femoral epiphysis here. Okay, this is called skiffy, and where we usually see this skiffy? Yes, which age group? Teenage. And these patients, they present usually with
teenage.
other age groups, like other endocrinopathies, that is diabetes mellitus, hypogonadism. Okay, so this you have to remember, other endocrinopathies in case of teenage who are obese. So obesity is one of the important factor. Okay, so what is the importance of this? You see, what is this? This is called the what line? What line is that? Kleene line, right? And what is the sign? Trethovan's sign. So this is called the Trethovan's sign. That means you draw a line along the lateral aspect, and it should pass through the epiphysis like this. So you will draw the lateral aspect and it will follow the epiphysis. But here if you see, you draw a line, it is not cutting the epiphysis. So this is called the Kleene line and this is called the Trethovan's sign. Okay, that is the importance of your skiffy. You have to remember, usually seen in teenage, especially in the males who are obese and suffering from other endocrinopathies. Okay guys? Yes? And what is this deformity? This is Springel's deformity, right? And this is your
Long thoracic nerve.
This is your Klippel syndrome. So these two are important syndromes they might ask. So it is already given here. What is Klippel? Your hairline. There will be low hairline, short neck, and there will be fused vertebra. And what is Springel's deformity? There is failure of descent of the scapula. Okay? Clear? So failure of descent of scapula and your Klippel. These two are congenital syndromes which you have to remember. And what are these tests for? These are for your carpal tunnel syndrome. So what is a carpal tunnel syndrome? There is a compression of the median nerve, right? So there will be a compression of the median nerve. Yes, and then there are various tests. So direct compression test is called Durkin. This has been asked in NEET PG. So there is a high chance of you being asked this year. So Durkin's is direct compression. And then we have Fallon's sign. So this is the Fallon's sign. And Fallon's sign is what? You're flexing the wrist, right? So this is the provocative test. So you're compressing the your carpal tunnel. So with this compression, you will have the median nerve, and then you will have the tingling and numbness in the 3.5 fingers. Okay. So usually this is mostly seen in the night time. So there will be tingling and numbness over the 3.5 fingers. So these are all the tests for your carpal tunnel syndrome. Okay. And then coming to the infections. So this is one of the most important X-ray. So this is an chronic osteomyelitis X-ray, right? So this chronic osteomyelitis, what you see, the most important thing you see is the sequestrum. So what is a sequestrum? Sequestrum is nothing but a dead bone. So this is the sequestrum. So this is the sequestrum, and the new bone is called the involucrum, right? So the new bone is involucrum. Very good. And what are the openings called? Cloaca. Very good. Cloaca. So these three are the important words: sequestrum, involucrum, cloaca. And how do I identify sequestrum? Sequestrum is again a dead bone. So something is dead is again sclerotic. That means it is dense. So dense white bone which is surrounded by lucency. So this lucency is nothing but it is the granulation tissue, right? So this is surrounded by lucency, which is the granulation tissue, right? So that is the definition of sequestrum. So it is a dense bone which is surrounded by granulation tissue. And there is a new bone which is involucrum, and these openings are called the cloaca. And what is this? This is Gary's sclerosing osteomyelitis. So this is some subacute type of osteomyelitis, right? So where your defense mechanism is good. So your defense mechanism is good. So hence you're able to control the infection. So this is just, you will see that there will be a increase of sclerotic bone here. So this is the Gary's sclerotic osteomyelitis. And what is this? This is Brody's abscess. So what is Brody's abscess? It is again a cyst-like. So where the body defense mechanism is good, right? So hence you are able to control the infection, and it is appearing as a cyst which can hold your infection. So this is Brody's abscess, usually seen in the tibia, right? So these two are the examples of subacute osteomyelitis. Yes, Dr. Raj, correct. It is Brody's abscess. Very good. Okay, now this is about the tuberculosis. So that is about the pyogenic infection. So the most common agent which is responsible for pyogenic infection in orthopedics is Staph aureus, right? It is Staph aureus. Remember, it is Staph aureus. And then we are moving up to your tuberculosis. Like 3 more slides, okay? And we are done. Okay, tuberculosis, this is an X-ray which has been asked in the Jan 24. Yeah, recently there has been asked this. Okay, sorry, 25 only, I guess. So this is the X-ray, this is the MRI, exact MRI has been put up in the exam, and they have asked what is this condition. So this is tuberculosis. So how do you identify tuberculosis? Of spine. So there will be destruction of the disc, right? So disc space is destructed. So there will be destruction of the disc space, and you will see there is a lot of pus which is forming. Okay, what is TB spine called? It is called the Koch spine, right? Very good.
Yes.
Koch spine. So TB spine is called the Koch spine. And what is this? Knuckle gibbous. What is knuckle? What is gibbous? What is kyphosis? So whenever there is involvement of one vertebra, it is knuckle. And gibbous is 2 vertebra. Kyphosis is more than 3. Okay? So this is called the Pott's spine. Okay? So this is called the Pott's spine, and this is knuckle, gibbous, and your kyphosis. Okay? And first what you see is there is a complete destruction of the disc space, and there will be a lot of pus which is formed there in case of your TB spine. Then comes the TB hip. So there are stages of TB hip. So the first stage is stage 1 is stage of synovitis. Second is stage of early arthritis. Next it is late arthritis, and then it is advanced arthritis. What do you mean by advanced arthritis? Where you will see the subluxation or dislocations, right? So what is this? This is called the wandering acetabuli. What is wandering acetabuli? So there is a complete destruction of the head, and head occupies one portion of the acetabulum. That is called the wandering acetabulum. And what is the next one you have to remember? There are 2 things. Motor and pestle appearance. So this is your motor and pestle appearance. So this is the motor and pestle. And the second one is your wandering acetabuli. Okay, these are the 2 important things which you have to remember in case of your TB hip. So one is wandering acetabuli, second one is motor and pestle appearance. Okay, and these are the stages in case of your TB hip. Okay, and in case of TB knee, there is one important condition which you have to remember, that is your triple deformity of the knee. So what is this triple deformity of the knee? So first you see there will be a flexion of the knee, and then you see there will be an external rotation of the tibia, and finally there will be posterior subluxation. Posterior subluxation of the tibia. So these are the 3 important deformities which you see in case of triple deformity, and this is not only seen in tuberculosis. How do you remember? This is seen in other conditions where you see TB, rheumatoid, ilioband contraction, and then you see in polio, and finally you see in hemophilia. So these are the areas where you see triple deformity. So there are so many options which can be asked in the exam. So what you have to remember is there is triple deformity is the 3 conditions. So first is flexion of the knee. Then you see the tibia is externally rotated. That means the knee will be presented in valgus. And then you will have posterior subluxation. Okay. And these are the other areas where you can probably see your triple deformity. Is that right? Sleeping, everybody? Okay. All dull voices now. Okay. Now this is the last one and we are done. Okay. This is the last one. Sorry, I'm extremely sorry. So this is about the metabolic disorders, and this is very important. Okay, just give me 5 more minutes and we'll be done. Okay, so what is the first one? So this is, so you can see some fractures there. The arrow mark is pointing out at some fracture. Yes, you can see or not? So this is,
Yes, ma'am.
this is osteomalacia. So what is osteomalacia? There is decrease in vitamin D in case of adults. So decrease in vitamin D in children is called rickets, and decrease in vitamin D in case of adults is called osteomalacia. Okay, so these are small fractures which are not very important, and these are usually seen in the osteomalacia. And what is this? This is important. This is asked in the exam. This is called protrusio acetabuli. Yes, this is protrusio acetabuli, usually seen in case of your osteomalacia. Okay. Yes. Bayan left. And what is this? This is usually hyperparathyroidism. So what is hyperparathyroidism? So there will be an increased levels of parathormone, right? And this parathormone causes increase of resorption of the bone, right? So whenever there is an increase in resorption of the bone, we usually see it on the hands. Yes, very good, Dr. Raj. And this is usually seen on the radial side of the phalanx. So these are phalanges, and you see the radial side there is resorption. So this is all the radial side which is the resorption is seen, right? And this is an example of hyperparathyroidism. And what is this? This is Brown's tumor. Brown's tumor. Again, it is seen in hyperparathyroidism. This is also called as, Brown's tumor is also called as fibrosis osteitis cystica. Okay, fibrosis osteitis cystica. Just nothing but the condensation of the fibrous tissue, which is liquefaction of the tissue which is present, and it appears as the tumor. So this is called as the Brown's tumor, usually seen in your hyperparathyroidism. Okay, then what is this? Picture frame vertebrae. This is called your picture frame vertebrae. And what is this? This is your ivory vertebrae. And what is this? Rugged jersey spine. Okay. So this rugged jersey spine is seen in Paget's disease, or it can also seen in your hyperparathyroidism. And finally, what is this? Fishmouth vertebrae or codfish vertebrae. So this is seen in osteoporosis, right? Yeah. Fishmouth vertebrae. And finally, the last one, bullet-shaped vertebrae. Where it is in bullet-shaped vertebrae? Achondroplasia. Okay, this is seen in achondroplasia. Okay, so these are all the various spine, and their importance of x-rays, very important. They will ask in the exam. So picture frame and ivory vertebrae, it is usually seen in Paget's disease. Okay, and rugged jersey spine is seen in Paget's disease and can also be seen in your hyperparathyroidism also. Okay, and finally codfish vertebrae or fishmouth vertebrae in osteoporosis, and bullet shaped in achondroplasia. Yes, Dr. Raj, you're right. Achondroplasia, bullet shaped vertebrae. Okay, is that clear?
Yes, sir.
Okay, and finally this. What is this? This is osteogenesis imperfecta. So what is osteogenesis imperfecta? Where you see there is a damage to the collagen. So there will be COL-A1, A2 genes which are defective, and it will result in decreased collagen, and the patient will present with multiple fractures. Okay, but healing is good. That you have to remember. So healing will be good, but the patient presents with multiple fractures. So this is usually a congenital disorder, osteogenesis imperfecta. Okay, this you have to remember. And these are two important footwear. I mean, this is for usually for people who have undergone amputation. Okay, so this is the Sach foot, and this is your Jaipur foot. Okay, Sach foot is nothing but your solid ankle cushion heel. Okay, Jaipur foot has been developed by Dr. P.K. Sethi, and this is developed in Jaipur. So hence the name Jaipur foot. Okay, And what you have to remember is this is not very, very useful for Indian condition. Okay, because it is made by solid ankle cushion. That means you can't do anything with that. So there are no movements which is possible, and you have to always wear footwear. You can't wear it on bare walking. But Jaipur foot PKC has been used multiple blocks. There are 3 blocks which have been combined, and you can do all the movements such as plantar flexion, dorsiflexion, and you can do barefoot walking also with this. So this is mainly developed for the Indian scenario, right? So Indian scenario is Jaipur foot. Okay, just remember that these are the 3 blocks. So first one is the ankle block, then you have the forefoot block, then the heel block. These are separate blocks, and this, with the help of these blocks, we can do multiple movements. Okay, and you need not use footwear. I mean, you cannot, you can use it on barefoot, and you can use it on the uneven walking also. This always required boots, and you can't do uneven walking. Uneven walking not possible. Just remember there are 2 important things. One is sachet and one is the Jaipur. Jaipur is good for your Indian system. Okay, and finally some soft tissue. So what is this? This is dupuytren's contracture. So you can see cord-like things on the hand. So this is your dupuytren's contracture. So these are thickened cords. Okay, your palmar fascia gets thickened and appears as the cord. So this is dupuytren's contracture. Okay, and what is this? This is your trigger finger. So trigger finger is nothing but there is a problem in the pulley. Okay, so especially the A1 pulley, which is at the problem, and whenever these pulleys, these tendons, we go through the fingers like this, and here they will be pulleys. So these are the area where the pulleys are present. So as they pass through the pulley, and because of the tightening of the synovium there, it produces sound. So that is called triggering. So that is your trigger finger. And finally, this is your prayer sign. Prayer sign, where you see diabetic chirioarthropathy, right? So this is the condition where in diabetics they will develop contractures in the joints and they cannot do this properly. So when you ask them to put hands like this, they cannot do this. So this is your prayer sign. Okay, and finally, not to forget your instruments, which are very, very important. So this is your periosteum elevator. So whenever you want to fix the plates onto the bones, you have to remove the periosteum. So for that, we use the periosteum elevator. And what are these? The second ones? Osteotomes. The second one is osteotome. You can see there is a sharp edge. So these are mainly used to cut the bone. So whenever you want to do osteotomy, so use the osteotomy and you will break the bones. And finally, this is your plate. So this plate is nothing but your dynamic compression plate. So DCP, how did I identify this as DCP? So you will have combi hole. Combi hole, that means, not the combi hole, you will have the oval hole. Okay, and whenever you want to identify LCP, that is compression plate, you will have the combi hole. That means in locking compression plate, you will have 2 holes. So one is like this, and the second one is with the threads. Okay, so whenever you see the threads, you identify that as locking plate. Whenever there are no threads, which is plain like this, and you see only an oval hole, this is your DCP. That is your dynamic compression plate, and it is used for fixation of the fractures. Okay, so this is a plate. Dynamic compression plate. Okay, is that clear? So that comes to the end of the class. Thank you so much, and I'm absolutely sorry for taking a lot of time. Hope this helps in the exam, for putting a lot of efforts. Any doubts you have? Yes?
No, ma'am.
Everything is clear? So if you have any doubts, you can, if you have any doubts, you can post it on the Telegram group. I will reply, or else you can DM on Dr. Alekhya Ortho. This is my Instagram handle. or you can PW MedEd. Our team will get back to you with the answers. Okay. Sorry, good night. Yeah.
Can we get this PDF, ma'am?
Sure. Without PDF, it is not possible for you to revise. So complete PDF, we will post it on the Telegram group. Nothing to worry about the PDF. Okay. And guys, please keep revising, because orthopedics is somewhat volatile. You keep forgetting, and sometimes 2 or 3 like Thompson's and Thomas, you get confused. So please keep revising. Okay. And anything you please put up on the Telegram. Okay. So let's end the class.
Thank you, ma'am.
Yeah, thank you so much.
Thank you.
Yeah, thank you. I'll just post the PDF. Just now I will do it. Okay. Yeah, thank you. Good night. Bye.
Good night, ma'am.
Good night. Okay. Thank you, Rishabh. Raj, Kalai has left. See you all in the next class.